all for today's webinar, Innovations in Lymphoma Therapy, Updates for Clinical Practice. With immense pleasure, I would like to invite Dr. Rachan Shetty, who is Consultant Medical Oncology, AJ Hospital and Research Center, AJ Institute of Medical Sciences, Mangalore, for the welcome and introductory note. The stage is all yours, sir. You can start.
At the outset, I would like to thank Horizon Group for hosting this session. And I would like to thank our sponsors, Roche, Glenmark, Zydus, Takeda, and Natco. Today's meeting is Innovations in Lymphoma Therapy and Updates for Clinical Practice. As we know, lymphoma is a treatment is rapidly evolving, and there are newer treatments which have come. The first session would be on Hodgkin lymphoma, and the talk is upfront therapy in Hodgkin lymphoma, optimizing cure with the chemo plus immunotherapy. And this talk would be presented by Dr. Vijay Shetty, who's a dear friend and HOD of medical oncology at K. Segde Medical Academy, which is a comprehensive onco center. Over to Dr. Vijay.
Thank you, Dr. Rachan. At the outset, I would like to thank you for having me join today's meeting. So I think I'm already late in presenting my slides. So without wasting much time, I'll be giving my talk now. So is my screen visible?
Yes, sir, it's visible.
I'll maximize it. Yes, yes.
Yeah, okay.
So today we'll be discussing about the transforming frontline therapy in Hodgkin's lymphoma, and we'll be looking at what are the various strategies which we can utilize to optimize the patient's outcome. So at the end of my presentation, we are going to look at the various biomarkers which are going to be discussed in the field of Hodgkin lymphoma and how we can utilize them in our modern day practice. So by now, everyone is using PET-CT scan as a standard tool for assessing the outcome for Hodgkin lymphoma patient. So we do interim PET at baseline and interim PET after 2 cycles ABVD. And now we are fairly confident in predicting the patient's outcome. If someone has a PET2 positivity at the end of 2 cycles, we tend to escalate the treatment. And if it's negative, we are kind of assured that the patient may have a better outcome. So actually, it's a SWOG study, which was a PET-guided multicenter phase 2 study, which gave us the preliminary data, where in advanced Hodgkin lymphoma, we would give 2 ABVD and get a PET positive, we would escalate to the BIACOP regimen, escalated BIACOP, 6 cycles. And if interim PET was negative, we would give 4 more cycles of ABVD. The primary endpoint was 2-year PFS, and the secondary endpoint was OS. And as we can see here, 5-year PFS by PET2 designation, those who were PET2 negative had a much better outcome compared to the PET positive subgroup. Also, there were a lot of parallel studies happening about 10 years back as to how to escalate or de-escalate based on the response to treatment in advanced stage Hodgkin lymphoma. So this was a UK RATHL study where a lot of patients with almost close to 1,000 patients were randomized, most with stage 2 adverse, stage 3, stage 4 Hodgkin lymphoma, varying between various IPS scores were taken, and they were all randomized to ABVD 2 cycles and interim PET scan. PET positive were then randomized to escalated BIACOP or 4 cycles or 3 cycles. If PET3 was positive, they would be then subjected to salvage chemotherapy or radiotherapy. PET3 negative received 2 more escalated BIACOP. PET negative had either ABVD or AVD that was aimed at treatment de-escalation, those who had an interim PET negative, whether we could avoid the bleomycin toxicity. So that was one objective of the study. So we can see here in the advanced Hodgkin with the negative interim PET, it was safe to omit bleomycin with minimal consolidation radiotherapy, and the results were results were similar to the SWOG 816 trial. 25% of the patients with negative PET2 will again relapse. So there is some unmet need there. And again, then with the ADCs coming into the picture, the Echelon 1 trial where the anti-CD30 brentuximab vedotin was combined with AVD, and this was compared with the standard ABVD in newly diagnosed stage 3, stage 4 Hodgkin's lymphoma. Patients who had adequate renal and hepatic function with the performance status of 0 to 2 were enrolled in the study. Interim PET, end of cycle to PET, if the dual score was 5, they could be switched to the treatment of physician's choice. So brentuximab vedotin with the AVD, one in every 15 days. So there are almost 670 patients in each arm, and the patients are followed up every 3 monthly for 3 years. Thereafter, every 6 monthly. Primary endpoint was PFS, and the secondary endpoint was overall survival and response rate and duration of response. So we can see the long-term follow-up of PFS, OS, and other outcomes. We can see that brentuximab vedotin scored over ABVD here. And the OS was also more in favor of the brentuximab arm, albeit at a slightly higher risk of febrile neutropenia and peripheral neuropathy, which was seen more commonly with brentuximab arm compared to the ABVD. Coming to the next topic of checkpoint inhibition in Hodgkin lymphoma, we know that this is an immune-rich tumor. So there was a lot of interest in exploring the roles of PDL1 inhibitor. So PD1, PDL1 was studied extensively, and nivolumab actually had an overall response rate of around 70% in the brentuximab naive cohort, and even in those who relapsed post transplant. So, why is it so sensitive to PD1 inhibition? The Reed-Sternberg cells exhibit frequent copy number alteration in 9p24 and the genes encoding the programmed death receptor ligands and PDL1 and PDL2. So, highest single agent response rate is seen in actually in Hodgkin's lymphoma. So the mechanism is quite complex, and the immune signature is pretty rich. This kind of makes Hodgkin's a very ideal candidate for immunotherapy. So so standard management as of now has always been ABVD. So the newer options like brentuximab and nivolumab are being looked into. So incorporating PD-1 blockade in first-line Hodgkin lymphoma, we know that it's very well tolerated. That's why new AVD kind of studies started coming in. And we saw that in early Hodgkin lymphoma, they have an excellent 3-year PFS study, 3FS data. So also Pembro is being looked into the same space. So this is another SWOG study which compared Nivo versus brentuximab for frontline classical Hodgkin's lymphoma. This is a randomized international phase 3 trial, and patients about 12 years of age were enrolled, those with stage 3, stage 4, and having adequate creatinine clearance and healthy ejection fraction of more than 50% when enrolled with normal LFT, and those with active autoimmune diseases were kind of removed from the study as immunotherapy was involved. And nivolumab was combined with AVD on day 1, day 15, 28-day cycle. So 6 cycles versus brentuximab day 1, day 15 with AVD, 6 28-day cycles. So end of treatment radiation was allowed in the pre-specified patients. So as we can see, the baseline characteristics in both the groups were very well matched. Majority of the patients were in the age group of 12 to 60 years. Few elderly patients were also there. And they had a healthy mix of B symptoms and bulky disease as well. So as we can see, the adverse event in more than 10% of the patients, the Nevo AVD arm had actually more of nausea, fatigue, and the neutropenia was kind of comparable in myelosuppression was comparable in both the groups, and other side effects like other adverse events like thrombocytopenia were kind of dismal. So, but overall, Nevo AVD was better tolerated than brentuximab vedotin and AVD combination. The incidence of neuropathy was much lesser in the Nevo AVD arm, and also the incidence of infections and febrile neutropenia and sepsis was comparatively lesser in Nevo AVD arm compared to the brentuximab arm. Also, treatment discontinuation was lesser in the Nevo AVD arm compared to the brentuximab vedotin and AVD combination. And need for subsequent radiotherapy was also almost comparable in both the arms. The PFS benefit of Nevo AVD was sustained with 2-year follow-up. So in the elderly age group, especially, I think Nivo-AVD is one combination which can helps a lot of our elderly patients where the risk of neutropenia and neuropathy is much higher. So that's the PFS study data and all the subgroups. We can see that all the subgroups actually showed benefit in the Nivo-AVD arm. And even the OS was more or less comparable, but I think in the Nevo AVD, the elderly population are the ones where probably that combination will work much better. Now, coming to the reducing toxicity with escalated BioCop. So this was the HD21 study, which is a randomized non-inferiority phase 3 study, where patients between the age of 18 to 16 were enrolled. Those with stage 2B and above with large medicinal mass, and these are high risk stage 2 and stage 3, stage 4 patients were enrolled. And this was basically a patient study done in the younger age group patients. So escalated BioCop 2 cycles followed by interim PET versus Bricad 2 cycles. I will come to the drugs in both the protocol shortly. So those who were interim PET negative in the BioCop arm were then went on to receive 2 more cycles of escalated BioCop. So those who had a positive interim PET in the BioCop went on to receive 4 more cycles of escalated BioCop. Likewise in the comparator arm as well. So as you can see, these were the drugs which were there in the Bricad regimen. That is, bleomycin was actually omitted, and instead of that brentuximab was used, as a result of which pulmonary toxicity was much lesser in the that was the whole point in deciding this trial. So with omission of bleomycin, there was reduced pulmonary toxicity, and etoposide doses, as you can see here, is slightly lesser in the Bricad regimen, reducing hematological toxicity and transfusion requirement. And vincristine is totally skipped, so that will reduce the incidence of peripheral neuropathy. Also, procarbazine is not there, so that reduces the gonadal toxicity and secondary neoplasm. Gonadal toxicity, especially in males, so they regain the fertility much faster compared to the escalated Biocop regimen. Also, dacarbazine is a very important drug which has shown it's kind of indispensable drug in Hodgkin lymphoma treatment. We have seen very high response rates with dacarbazine. So it's a very important drug which was missing in the escalated Biocop. So that has been included in the Bricad regimen. So if we see, the gonadal toxicity in the females was also lesser in the Bricad regimen compared to even in the males it was lesser. So in terms of infertility, Bricad was much superior to the Biocop in terms of gonadal toxicity, and it also improved PFS versus escalated Biocop. But the practical limitation is it causes more myelosuppression. The need for RBC transfusion is much higher. Thrombocytopenias are much higher. So the incidence of infection, thrombocytopenia is much higher. That's why this was tried in the 18 to 60 age group. And the need for consolidative radiotherapy is much higher in the Bracard compared to the SWOG study. So these are all the new changes which are happening in the space of Hodgkin's lymphoma. Nevo AVD improves PFS compared to brentuximab vedotin AVD in advanced Hodgkin lymphoma. So this is something which we can definitely offer the elderly patient. And there's much lesser incidence of immune-related adverse events. And even the need for subsequent RT is much lesser. So in all ways, probably in the elderly, Nevo AVD is the regimen which might become standard of care. Bricad improves PFS and with much lesser gonadal toxicity compared to escalated Biocop. So in the young patients, probably that is the regimen which we'll be using in the future. So current management for advanced stage Hodgkin lymphoma and the elderly, probably if you look at, we'll be probably choosing Nevo AVD over ABVD, and in the younger, probably if the patient do not have adequate response to ABVD, standard ABVD in the interim PET, if it is positive, probably Bricad is the regimen which can think about. In some circumstances, we can also look at the UK RAPL study and also the Echelon and other, which I think we'll be discussing shortly in the panel. So going forward, I think CGP is going to become standard in even Hodgkin lymphoma. Also, ctDNA will be looked into, and also MRD also will be slowly. We'll be looking at the MRD positivity, negativity as well, and the biological subtypes will be defined more often in Hodgkin's lymphoma. We'll be looking closely whether the patient is having a EBV positivity or not, whether it's an inflammatory immune immune-rich Hodgkin lymphoma, if there's an oncogene-driven Hodgkin lymphoma. So probably in the future, we'll be classifying patients more on those lines rather than in the classical and NLPHL classification. So we'll be looking more into the immune environment of the Hodgkin's lymphoma. So these are some interesting phase 2 studies which are happening. So for stage 2 bulky disease, stage 3, stage 4 patients, they're looking at brentuximab, combining brentuximab and nivolumab, and dacarbazine and daunorubicin. I mean, the incidence of peripheral neuropathy is much higher with this, and grade 3 adverse events are much higher. But this is something which is being tried, and also a lot of risk stratification based on interim PET, whether to randomize to those who are having inadequate response to whether they should be they are going to receive brentuximab with nivolumab, or whether to combine nivolumab with ABVD. But all these come at a slightly higher risk of peripheral neuropathy. And I think this ASCO also, there was a lot of discussion on the newer drugs like sintilimab plus ICE for those who failed first-line chemotherapy. And CAR T cells is being discussed as well, CD30 CAR T cells. They have impressive overall response rate of 72%. So there's a lot of things happening. Pembrolizumab combination with the vorinostat, HDAC inhibitors. So a lot of exciting trials and data coming in. So the future of Hodgkin's also looks pretty positive in terms of the relapse setting, and a lot of ongoing trials which are happening in this space, and a lot of newer therapy options are being tried. So the future of Hodgkin lymphoma in the both upfront and relapse setting seems quite exciting.
The
So with that, I think I've come to the end of my presentation. Now over to Dr. Rachan. Thank you very much for the opportunity.
Thank you, Dr. Vijit. It's a very well done presentation. We'll discuss regarding further about Hodgkin lymphoma in the next panel discussion. Next, we'll talk about the next study, which is sponsored by Takeda. Um, Advancing Hodgkin lymphoma care and the essential role of ADCETRIS in every stage. For this talk, I would like to welcome Dr. Karthik S. Udupa, who is the former HOD of Department of Medical Oncology at KMC Manipal. Over to Dr. Karthik Udupa.
Yeah, thanks, Rachan. Thank you for the introduction. And without much delay, I would like to share my slides. Kindly let me know if my slides are visible and am I audible?
Yeah, slides are visible.
Yes, slides are visible. I think I'm audible also, right?
Yeah, yes.
Yeah.
Yes.
At the outset, I would like to thank Rachan and team for inviting me as a speaker for this extremely well thought program on lymphomas. And I would also like to thank Takeda for giving me an opportunity to present on this topic, advancing Hodgkin's lymphoma care, the essential role of ADCETRIS, that is brentuximab vedotin, in every stage. Sorry. So. Disclaimer, all the slides are provided by Takeda team. And what am I going to speak in next 20 minutes? It is advancing Hodgkin's lymphoma care, the essential role of ADCETRIS in every stage. I will be talking about in the frontline Hodgkin's lymphoma, the role of ADCETRIS in relapsed refractory Hodgkin's lymphoma, and also post-autologous stem cell transplant consolidation setting in Hodgkin's lymphomas. So coming to the first indication, that is frontline Hodgkin's lymphoma. So few slides on introduction of Hodgkin's lymphoma. The incidence of Hodgkin's lymphoma, we all know that it has bimodal age distribution. The first peak is between 20 to 34 and the second peak is above 75. But you can see that the mortality goes on increasing as the age advances. And the survival outcome for an older patient is not as good as that with the younger patients. The 5-year overall survival in those patients with less than 60 years is around 90%, whereas it drastically drops down to around 58% in those patients with Hodgkin's lymphoma above the age of 60 years. So as a dictum, we tell all the patients that Hodgkin's lymphoma is a curative disease because we are able to cure around 80% of Hodgkin's lymphoma across all stages. And the highest success rate, as I told, is among the youngsters between the age of say 15 to 39 years, and also in those patients who have early disease. But among the patients with classical Hodgkin's lymphoma, we know that there will be one odd man out of say 10 or 100 patients we treat. There will be a patient who will be primary refractory disease, which accounts for around 5 to 10% of overall Hodgkin's lymphoma population. And we also experience around 10 to 30% relapses after an initial response. So this overall we can expect around 80% cure rate. And among the patients with advanced Hodgkin's lymphoma treated with first-line ABVD, around 30% of the patients will progress or die within 5 to 7 years. And we all know that ABVD was the standard of care. I think last 3 to 4 decades, we were giving ABVD for all the stages of Hodgkin's lymphoma, and there was no regimen which was better than ABVD when pertaining to the progression-free survival or the overall survival. Although many combinations were tried, nothing beat no regimen beat ABVD. So ABVD was the standard of care for probably last from say 1970s to 2010. So what are the problem with the ABVD or the treatment of Hodgkin's lymphoma with the multi-agent chemotherapy? So the various problems which we have to encounter when we are treating a patient with the Hodgkin's lymphoma is endocrine dysfunction, hypothyroidism can occur in Hodgkin's lymphoma patients, especially in those who have received radiotherapy to the neck region, fertility issues. Even though ABBD is not a drug which produces a lot of fertility issues, but still we can have around 5 to 10% of the patients who will have fertility issues. Pulmonary toxicity is the major issue with ABVD. Bleomycin is a nasty drug which produces pulmonary toxicity, and we have had instances where even the patients have died because of pulmonary toxicities, acute treatment related toxicities, which are probably very well managed with medical when a patient is in the medical oncologist's hand. Cardiac defects, we have to be careful about the anthracycline-induced cardiomyopathy, secondary malignancies. Few of the patients do experience secondary malignancies, especially breast cancer and radiation-induced thyroid cancers. Very rarely the patient can also have death after the treatment of Hodgkin's lymphoma with multi-agent chemotherapy. So I think for as a clinician, I am more worried about the bleomycin induced pulmonary toxicity, because it is one of the condition which actually hampers our treatment, and severe bleomycin induced pulmonary toxicity can account for death also. So if we can probably take away bleomycin from the ABVD regimen and replace with any other novel or a newer therapeutic agent, it is most welcome. And first on cards in this effort was Adcentris with ABD, which produced a better overall response results compared to ABVD in the Echelon 1 trial. And also there is the other regimen which are approved are, apart from ABVD and Adcentris AVD, it is Bakov. But there is, we all know that Bakov, escalated Bakov, we have to be little careful about the added toxicity. Even though there are other regimens which are tried out, like as Dr. Vijit told, Bricad and Nivo AVD. Nivo AVD has come into frontline Hodgkin's lymphoma treatment according to NCCN. But I think in 2023, still India did not have the permission to use Nivo AVD combination. So if somebody asks what defines the success of Hodgkin's lymphoma, it is always the cure, and overall survival is a surrogate marker, and whichever or whatever regimen produces the most or the highest overall survival probably is the one which we need to use. And as I told, ABVD was a combination which actually did not have any competitor. Now, after say 3 to 4 decades, Adcentris with ABD actually produced better overall survival. and I'll come to the trial a little later. And because of this trial in advanced Hodgkin's lymphoma, Adcentris with AVD became the standard of care. So the trial which I'm going to speak is Echelon 1 trial, where the patients with the Hodgkin's lymphoma advanced stage 3 or 4 above the age of 18 years were randomized in 1:1 fashion. The number of patients who are included in this trial were around 1,334, where patient one arm received 6 cycles of ABVD and the second arm received Adcentris plus ABD. After 2 cycles, PET scan was done, and only in those patients who had a dual score of 5 were actually taken out of the trial, and the alternative regimen was used. Rest all patients were continued for 6 cycles of chemotherapy, and end of treatment PET scan was done. So the primary endpoint was median progression-free survival, and the secondary endpoint was overall survival. So if you come to the primary endpoint, that is a progression-free survival, at 2 years itself, the progression-free survival with the Adcentris plus AVD was 82.1% versus 77.2%, with the hazard ratio of 0.77. And interestingly, the PFS went on increasing, and the benefit was better with the brentuximab ABD compared to ABVD. And at the end of 6 years, the probability of 6 years PFS and the 7 years PFS was 82.3 versus 74.5, with a p-value of 0.002 and 0.001 respectively, with a significant hazard ratio which was better than 2-year PFS. So statistically significant difference in favor of Adcentris plus AVD compared with ABVD at 2 years, and the superior efficacy of Adcentris plus AVD compared to ABD was maintained at 6 and 7 years. Coming to overall survival, a trend towards overall survival was observed at the end of 2 years, with the brentuximab plus AVD 96.6% versus 94.2% favoring brentuximab AVD, with the hazard ratio of 0.73 and p-value of 0.2. But this overall survival actually became significant, statistically significant at 6 years and 7 years, with a p-value of 0.009 and p-value of 0.011 at 6 and 7 years respectively, favoring the brentuximab ABD versus ABVD. So this was the first trial which actually showed a superior overall survival benefit compared to ABVD in advanced Hodgkin's lymphoma, and that is why this combination made a lot of buzz in the oncology fraternity. And did it had an impact in all the patients, or only on those patients who had favorable outcome? The answer is this brentuximab AVD combination did well in those patients who are stage 4, those patients who had extranodal disease, one or more than one extranodal disease. So in high risk population also, the brentuximab AVD did do better compared to ABVD chemotherapy. So this is a real world survey among the oncologists, where the preference or the most preferred outcome was actually tabulated, and the survey showed that most of the oncologists relied upon the overall survival benefit, and compared to other parameters like PFS or complete response rate. So the most important thing was overall survival, and the brentuximab AVD had a better overall survival compared to ABVD, and this is why the oncologists had a satisfactory. This combination actually satisfied the most of the oncologists' expectation of having a better overall survival results compared to ABVD. So where exactly this combination can be used? It can be used in those patients above 18 and less than 65 years, and patients with advanced Hodgkin's lymphoma stage 3 and 4, and with high risk IPS between 4 to 7, and also in those patients with more than one extranodal cells. Okay, so coming to the second scenario, that is relapsed refractory Hodgkin's lymphoma, the role of Adcentris. So we know that this is a scenario where, this is a difficult scenario where the patient has relapsed after the autologous stem cell transplant, and we are mostly left with not much of an option. And before, I mean, say a decade earlier, we were just banking on oral metronomic chemotherapies and just prolonging the life for say a few months to few years. But this trial, that is SGN 35003 trial, clearly showed that Adcentris post autologous stem cell transplant failure had a significant PFS and OS benefit. And this trial was an international single arm multicenter phase 2 trial of Adcentris, and which was designed to determine the overall response rate in heavily pre-treated post autologous stem cell transplant patient, with key endpoint assessed by the IRF. The primary endpoint was overall response rate. The secondary endpoint was duration of response, CRH, PFS, and OS. And this was given in the key inclusion criteria was relapsed refractory Hodgkin's lymphoma after a high dose chemotherapy and autologous stem cell transplant. So the patient has relapsed after a high dose chemotherapy, patient more than 12 years, FTG, avid disease post transplant, and ECOG 0 to 1, where the patients were given Adcentris at the dose of 1.8 mg per kg Q3 weekly, and up to 16 cycles could have been delivered in this trial. And PET scan was done at the end of 4 cycle and 7 cycle, and CT scan was done every alternate cycles. So you can see here that the overall response rate was as high as 75% with Adcentris, and among 75%, 34% achieved CR. So this is this is a very, very encouraging result, especially in those patients who have failed after the autologous stem cell transplant. And if you see the waterfall plot also, we can see that 94% of the patients achieved some tumor reduction, and the majority of the patients achieved more than 50% reduction in the tumor burden. So what is the median time to achieve such good a response, or the maximum response? It was 5.7 months to get the best overall response rate, and to get a CR it was around 12 weeks. Sorry, 5.7 weeks and 12 weeks. So pretty quickly they will start responding, and the CR is achieved at the end of say 4 to 5 cycles. So the probability of overall survival was, the median overall survival with Adcentris was as high or as long as 40.5 months, and the probability of PFS was 9.3 months with the Adcentris in these patients who had failed after the autologous stem cell transplant. So as I told before, the time to response, I told that it was around 5.7 weeks. That means in probably 2 to 3 cycles itself, the patient will start showing response. And in the real world scenario also, it was around 6 weeks. So the time to response is an important consideration when treating patients with advanced disease or bulky tumors, and patients progressing on autologous stem cell transplant. So the patient will get a relief within 2 to 3 cycles of Adcentris in this scenario. So in the relapsed refractory Hodgkin's lymphoma scenario, where Adcentris should be preferred, autologous stem cell transplant eligible, but the patient has, due to poor second line response, so you want a bridging therapy, you can give some Adcentris, get the tumor reduced, tumor burden reduced, then patient can go for autologous stem cell transplant. Relapsing post autologous transplant ineligible, relapsing after 2 prior treatments, and with comorbidities and poor performance, who are ineligible for chemotherapy also, Adcentris can be given. So coming to the third indication, that is post autologous stem cell transplant in consolidation Hodgkin's lymphoma. So disease related and the patient related pre-transplant risk factors which may increase the chance of early post-transplant progression or death are: if the patient already has a bulky disease, more than one extranodal areas prior to the autologous stem cell transplant, patients who have a refractory Hodgkin's lymphoma, or patient who relapses early, that is less than 12 months of treatment of Hodgkin's lymphoma, more than one relapses or multiple prior regimens, especially more than 2 to 3 regimens if already has been tried, chemo resistant disease, pre-transplant PET positivity, B symptoms at diagnosis and relapses, and anemia pre-transplant. These are the risk factors which will predispose these patients, or give a clue that these are the patients who may fail post-transplant. So we need to be very careful about these patients, and we need to closely monitor in this patient in the post-transplant setting also. So this is a paper which was produced in British Journal of Hematology in 2012, where it showed that refractory patients and early relapsers have worse outcome overall survival than the late relapsers. The one in the black is late relapsers who did better post transplant compared to those with early relapses or patients who had a frontline treatment failure. And this is the same paper where it was shown that the patients who are exposed to more than 2 lines of chemotherapy before autologous stem cell transplant had a significantly worse outcome than those patients who received less than 2 lines of chemotherapy. So, how to prevent a disease progression or relapse after autologous stem cell transplant? Achieving a CR and PET negativity together before autologous stem cell transplant is not always possible. So, what if the risk factors are present? What I have already told, and we need to carefully evaluate the risk factors from diagnosis throughout the course of the disease, and probably in those patients who have a have these risk factors, consolidating these patients with a chemotherapy or a newer agent will probably prevent the relapses. And if we have an agent which can be given post transplant to consolidate the transplant benefit, may result in a better PFS in these patients who have a high risk of relapse. So this trial was designed. This is called Athera trial, which is a phase 3 international multicentric double-blind placebo-controlled randomized trial comparing Adcetris plus best supportive care versus best supportive care plus placebo. And the patient's primary endpoint was the progression-free free survival as per independent review facility IRF. Secondary endpoint was OS. So how exactly this trial was designed? Post frontline therapy, restage risk factors assessed, and if the patient had refractory disease frontline, or if the patient has relapsed less than 12 months of frontline therapy, or if the patient has relapsed after 12 months of frontline therapy with the extra nodal involvement, patients were given salvage chemotherapy. And if the patient had CR, PR or stable disease, patients were taken for stem cell transplant. And post stem cell transplant, patients were given either brentuximab or placebo. Brentuximab was given at the dose of 1.8 mg per kg infusion every 3 weekly for 16 cycles. That is 1 year brentuximab consolidation post transplant in high risk patients versus placebo, which was again given at a dose of interval of 3 weekly for 16 cycles. So if you see the progression-free survival in this Atheroid study, there is an early separation of the curve, and the blue curve is probably it stands above the light brown curve, where which clearly states that the median PFS with Adcetris is better in all point of or all time frame, and the progression-free survival with Adcetris was not reached versus 15.8 months with placebo with the hazard ratio of 0.52. So the 5-year Adcetris continued to provide a sustained progression-free survival benefit, and it was actually beneficial in those patients who had more than 2 or more than or equal to 2 risk factors. So what were those risk factors? If the risk factors, there were 5 risk factors which were considered: primary refractory Hodgkin's lymphoma or relapse, less than 12 months from completion of frontline therapy, partial response or stable disease as the best response to most recent salvage therapy, extranodal disease, pre-autologous stem cell transplant. If the patient had B symptoms at pre-autologous stem cell transplant, or 2 or more previous salvage therapies were given, these were considered high risk factors. And if the patient had more than 1 or more than 2 or more than 3, this was these subgroup were again analyzed, and the patient with more than 3 risk factors actually had the major benefit from Adcetris compared to more than or equal to 1. So more than or equal to 2 or 3 high risk factors, that the addition of Adcetris in the post-transplant scenario was much better, even though the hazard ratio looks impressive with all either more than or 1 equal to 1 or 2 or 3 risk factors, but the hazard ratio kept on increasing with more number of risk factors. What are the major side effects with Adcentris? We all know that we have to be a little bit aware of the peripheral sensory neuropathy and neutropenia, but most peripheral neuropathy event in Adcentris group was it was grade 1 to 2 severity, and majority of the peripheral neuropathy resolved. Around 90% resolution or improvement was observed with the 73% complete resolution of peripheral neuropathy after 5 years of follow-up. So these are the real world studies which was done from Italy, and the next real world was from France and from Turkey. And the situation remains the same in high risk patients who have relapsed and post autologous stem cell transplant. Consolidation Adcentris versus placebo in all these real world studies, Adcentris clearly showed a benefit of consolidation brentuximab compared to placebo, where it had a better progression-free survival benefit. So, Athera conclusion was post autologous stem cell transplant consolidation with Adcentris for patients with classical Hodgkin's lymphoma provides greater PFS than placebo. The PFS benefits observed with Adcentris was maintained until the study closure, that is up to 10 years. PFS benefits was most pronounced in patients with more than 2 or more than 3 risk factors. Patient receiving Adcentris consolidation therapy required fewer subsequent anti-neoplastic therapies. Almost half, that is 47% of the patient in placebo arm received Adcentris as subsequent therapy. So considering each patient's complete risk factor profile from the diagnosis throughout the course of Hodgkin's lymphoma, it is crucial for the treatment decision, including consolidation with Adcentris. So with this, I would like to conclude my presentation, and I will hand it back to Dr. Rachini.
Thank you, Dr. Karthik. And you had elaborated on role of Adcentris at every stage, and it's truly a wonder drug. So next, we will be going on to the panel discussion, evolving standards in Hodgkin lymphoma management. And this panel will be moderated by Dr. Mangesh Kamath, Senior Consultant Medical Oncologist, proprietor of Helios Oncology Centers, and Additional Director of Fortis Hospitals, Bangalore. And to the panel, as panelist, I would like to welcome Dr. Naveen Anvekar, Senior Consultant Medical Oncologist at Apollo BGS Hospitals, Mysore. Dr. Abhay Kumar, Senior Consultant Medical Oncologist at Manipal Hospitals, Bangalore. Dr. Hemant Kumar, Senior Consultant Medical Oncologist at MIO, Mangalore. And Dr. Vijay Shetty, Professor and HOD, Department of Medical Oncology at K. Sigde Medical Academy, Deralkatte, Mangalore. Over to you, Dr. Mangesh. Thank you.
Good evening, everybody. Thank you, Dr. Rachan. Being the convener, you have put in a lot of hard work in creating this conference. And I would like to thank all the organizers of Innovations in Lymphoma Therapy Updates for Clinical Practice conference. And I have to apologize that I could not listen to a lot of my predecessors, because there is a puja that is going on in my clinic right now, and I completed it and joined it. But I'm very sure that Dr. Vijit and Dr. Karthik have given excellent presentations, having known them. And I will take the important points, having understood all the latest advances in Hodgkin's lymphoma. I will try to use two cases and trying to make it a little more relevant in our practice for all of us. So with this, I'll start my presentation. Welcome to my panelists, Dr. Naveen, Dr. Abhay, Dr. Hemant, and Dr. Vijit. I hope I am audible and my slides are visible. So let's start with the case of a 49-year-old male named Mr. Mohan, who had initial presentation of 3-month history of intermittent low-grade fever, night sweats, fatigue, noticed painless swelling in the left neck region with 5 kg weight loss over the last 2 months. On physical examination, it was the cervical and supraclavicular lymph nodes bilaterally were palpable, and the PET-CT showed multiple FDG avid nodes in the cervical, mediastinal, and abdominal regions. There was mild liver uptake with one focal avid lesion measuring 1.8 into 1.5 centimeters in the segment 7. The biopsy was done, or the whole node biopsy was done of the cervical lymph node. It showed nodular sclerosis of classic Hodgkin's lymphoma. We did a bone marrow biopsy because there was one avid lesion. Even though the PET did not show any increased uptake, there is no infiltration that was seen in the bone marrow biopsy. CBC is normal. The ESR is elevated. The ESR, just to be specific, is 54. Albumin is 3 gram per deciliter, and hemoglobin is 11.2 gram per deciliter. The stage was 4B. So just to refresh our memory, apart from the stage in stage 4, we also look at this IPS scoring in advanced disease, the albumin, hemoglobin, male, age more than 45 years old, stage 4 disease, and leukocytes and lymphocytopenia are seen. As per that, if you were to go back, you will see that albumin definitely was positive, male positive, age being more than 45 years positive, and stage 4 disease being positive. So 1, 2, 3, and 4. So IPS is 4, and the rest of them are all negative. So with this, I would like to start with Dr. Naveen. Dr. Naveen, how commonly do you see Hodgkin's lymphoma in your practice? If you were to see, say, 100 lymphomas, how many of them would be Hodgkin's lymphoma in your practice?
Hello, good evening. In my practice, I usually see around 20 to 25% of Hodgkin's lymphoma among all lymphoma cases.
Okay. And of this, what percentage of them are unfavorable, and what percentage of them are in advanced stage?
Around 60% are usually early stage, and around 30 to 40% are advanced stage. And among early stage, around 30% are unfavorable, and the rest are favorable.
Abhay, do you want to add something? How commonly do you see in your corporate hospital practice, and what percentage are unfavorable and advanced stage?
So I think so. Advanced stage, I see around 30 to 40%. So around 50 to 60% early stage, I see. In that, around majority will be like favorable only, unfavorable around 20%.
Okay. So it is very clear from both the panelists that advanced stage would be around 30%. One third of the practice, or one third of the Hodgkin's lymphoma we see would be advanced stage, that is stage 3 and stage 4. And of the patients, the rest of them, that is around 60-65% who would be in the early stages. Again, half of those patients. So another one third would be probably unfavorable. So just to add a little more context to it, Dr. Heyman, if you have treated 100 cases of Hodgkin's lymphoma, what kind of 5-year overall survivals do you see in all your cases of your 100 cases of Hodgkin's lymphoma?
Hi, good evening. Probably, I think a 5-year OS is beyond, I think, 70%. Most of the time it is beyond that. Even with the relapses, we have got few patients who have been going on multiple lines of therapy for years together. So OS is definitely great with these patients. I have a slight difference on the numbers that probably you see. I think I end up seeing being in Mangalore and towards the coastal belt, we end up seeing quite a lot of them not diagnosed in early stages. So probably advanced stages may reach around 50 to 60% and unfavorable being around 50%. A lot of them coming with really bulky disease. That is something that probably I see slightly different from the practice that you see.
So basically what you're trying to tell is that almost 2/3 of your patients are going to be unfavorable and advanced stage, or even probably 80% of them, right?
Probably 70%.
Okay. And just to add last, Dr. Vijit, what are your 5-year OS?
I agree with Hemant. Actually, we tend to see a lot of advanced Hodgkin. Maybe 60 to 70% are advanced Hodgkin or stage 2B and above. Bulky disease, neglected, or they come after multiple lines of Ayurvedic or alternative medicine. We're not done a data analysis per se, but analysis of all our data. But I think it's pretty high. Even though we get these advanced Hodgkin, I think most of them are doing well. The few, as expected, tend to relapse, but the majority tend to do well despite advanced presentation.
So basically, the ones in the coastal belt are saying that they get more advanced stages. And probably also there is an influence of indigenous medicines, whereas the ones from Mysore and Bangalore would probably see lesser advances, and more of early stage. Fair enough. So, how common do you do bone marrow biopsy after PET CT scan? Can I have a quick, comment from Dr. Naveen? How commonly do you?
Yeah, I usually take the PET scan if there are more than three this one focal lesions. I take it as usually positive two or more, and I usually don't do bone marrow. Only when there is a cytopenia for which the cause cannot be explained, I do the bone marrow.
Okay, so basically, if you are seeing something abnormal in the CBC, you would probably think of doing the bone marrow, right?
Yes,
And suppose there is a abnormality in the counts, and also the PET scan shows a diffuse uptake or probably focal uptake, would you still do it?
Uh, yeah, if there is cytopenia, definitely I will do it. But without cytopenia, diffuse uptake can be due to this is what are called cytokine-induced changes also.
Okay, Dr. Abhay, your thoughts on this? Suppose you have a patient with PET CT scan showing that there is uptake, diffuse uptake, or probably focal uptake. You have cytopenia, or probably even for that matter, increase in the WBC counts. Even in those cases, you will do bone marrow biopsy.
So I will consider only when if PET CT scan is suggestive of marrow involvement, I probably don't do. And also when cytopenias are there, I will do. And in normal scan, but patient is having very bulky disease, such patients also I may do.
Okay, fair enough, fair enough. So, what are your basic fitness evaluations that you do? You get a new patient of Hodgkin's lymphoma. This is a 49-year-old. Dr. Hemant, what are the basic things that you would like to take into perspective before you plan for the treatment of this patient? This is a stage 4 patient, stage 4B, IPS is 4. So, what are the things that you would like to make sure you do before you start to talk to the patient about what treatment regimen I'm planning for you?
I think the basic blood workup is something that we all of us do. Also rule out if any serological positivity is there. More importantly, I think cardiac fitness is something that all of us do if you are going to use anthracycline, because all these regimens do contain anthracyclines. So definitely an echo. I have not done PFT unless I feel I am compelled due to some history. Say if the patient has been a past smoker or has got some history of COPD, emphysema. If that sort of that, then probably I will do a PFT for documentation. Younger fit patient, I have not done PFT because DLCO access is an issue. So, and the reporting and how exactly they do it, I'm not too happy with it. So, I don't end up doing a PFT with DLCO on a routine basis. And most of the time, if I have given ABVD in the second interim PET, I do see mainly discuss with my radiologist for if any changes of bleomycin toxicities are there. We do ask them to not exactly like the 6-minute walk test, but at least we ask them to climb 2-floor flight of stairs, check for saturation before proceeding with every cycle of chemotherapy. So these are the basic workup that we end up seeing, trying to look for if any concerns for toxicity are there and then proceed.
That is very detailed, and thank you so much for that. What do you think, Dr. Vijit? Any additions, or do you want to do things differently from Dr. Hemant?
No, no, I think I agree with the Hemant completely. We do all of that. In addition to that, we do that PFPD also in our setup because we have a very good pulmonology team. And but then we do not disturb them every time for a PFA DLCO. We do one at a baseline, and then like something similar to what Dr. Hemant mentioned about
Okay.
the climbing
So
the stair
why
6-minute
I
walk
use
test.
this question? Why is the basic fitness important? Is we do see a lot of patients, and we would like to monitor their post treatment functions also. For example, as Dr. Hemant pertinently said, 2D echo is important because a lot of our patients will definitely get anthracyclines, and also it is recommended to do a DLCO PFT because you will also get to know whether your patient's pulmonary function is suffering while you are treating these patients. And we all obviously are aware that not everybody can take the latest ADCs or IOs in our practice. So it would be useful for us to know that when we are using bleomycin, what's happening to our patients. So this patient is stage 4 and stage 4B with the IPI4. So what are the most important considerations when you're planning for a treatment in these kind of patients, Dr. Naveen?
I would like to see his this in performance this in status. Any associated
His performance status is 1.
Yeah, any associated comorbidities?
None.
Okay, then I'd like to see whether the IPS score, if it is more than 4 or less than 4.
It's 4. I just
And
told his male albumin was low, and he had stage 4 disease, and
um,
yeah.
This one, no, I'm talking about this in general, not this case.
Okay,
And also any extra this nodal disease more than one, it will be.
yes.
And as such, this one, age is the most important, one of the most important factor, I think. Less than 60 and more than 60.
Okay, so just to make our audience understand, if it is less than 60, this patient is less than 60, what would be your plan? What exactly are you planning for this patient?
Uh, the thing is, my choice for stage 3 or stage 4 advanced Hodgkin's lymphoma, I would like to give if there are no contraindication for what I call immunotherapy, my choice would be new AVD based treatment.
Okay, so you said new. So suppose this is a more than 60-year-old patient.
Still, I would like to stick with new AVD or this one AVD for this one followed by this one interim PET. And if the patient is contraindicated for this one immunotherapy, I would like to give BV-AVD, and that too NCCN has given 2 cycles of BV followed by 6 cycles of AVD followed by 2 cycles of BV to what are called reduce the what are called side effects. We can try that, I feel.
Okay, so just one question to Dr. Abhay. You are planning to treat this patient on chemotherapy. For 49 years, do you actually look at fertility preservation? Do you have a discussion with your patients?
No, I will ask because by the time most would have been completed the family.
Okay.
But if somebody wants to preserve the semen, at least it is very easy for them.
Correct.
So we can give that option before starting, but based upon the person to person, case to case basis.
Okay, I actually had a real life situation where I had a 47-year-old patient whom I assumed that would not require fertility preservation. But that patient, thankfully for me, asked the question, Doctor, will I be able to have kids? And I said, have you already not had kids? And he said, no, I have not had kids and I would like to have kids in future. So yes, it is very important for us to ask one or two questions. Have you completed your family? And would you like to have more children? And if these questions are no, then probably I think we can probably look at not worrying about fertility preservation. So I'll come to Dr. Hemant on this question. This is I think you used about anthracyclines. Do you use atorvastatin with anthracyclines during treatment, Dr. Hemant? This patient does not have dyslipidemia, no diabetes, no heart problem, nothing.
Yeah. No. I haven't used atorvastatins specifically to see if I can offer additional cardio protection. I've not done that.
So I just wanted to bring to your notice about this very interesting study. And funnily, I actually went on this because I was looking for, atorvastatin in dyslipidemia while treatment of lymphomas. Right, I have a patient who had very bad lipid profile, and I was just typing this somewhere around 2024, and I found this very credible publication in which it was mentioned, and it was done in multi centers in US, and they did see that there was a significant benefit of using atorvastatin 40 milligram per day, irrespective of whether their lipids were abnormal or not. And it showed that the ones who received atorvastatin had a much lower decline in the cardiac function as compared to those who were randomized to placebo. So there are not too many adverse effects like probably myopathies and all that we've seen. And that compelled me to start the patients on 40 mg. And if those patients who were on 40 mg and had some side effects, mild side effects, I would probably bring them around 20 mg. So in my practice, I have started using atorvastatin for anthracycline associated cardiac dysfunction at least from the last 1 year. And I will continue to do so because the data of this study was pretty interesting. And I think some of us can read that to find out what exactly it can do in our practice going forward.
Yeah, I think this is one of the most important takeaway for me from this session. I think this is something that we have access to, which we can use easily, but probably this is never discussed. And I think one of the most important takeaway for me is this. Just wanted to know how long to use
During the therapy. You do not have
Only
to,
during the therapy.
yeah, that's the,
And
and in case the treatment is long, like why you're using, it says 1 year of treatment with atorvastatin. If you see the,
okay, great.
the key points written, 1 year would be enough. Minimum is to use it during the therapy. They have found no major issues with that. And it's a very interestingly made study. In fact, it is done in very good centers in the US, and they have included many centers, and 300 adult patients with lymphoma. They had Hodgkin's, non-Hodgkin's, and all of that. Whoever had to receive anthracyclines. I just thought I'll put this across to you because I have been using this in my practice for last 1 year.
Absolutely.
I just wanted to have a discussion and probably,
Yeah. Also, just one more additional question. Do you end up using now for CA breast patients also? Do you end up using
so
now?
that is an interesting question. So there is a study which was done on CA breast that did not show an improvement in the cardiac dysfunction. So I do not know the exact reason for that. In fact, one of our colleagues from Calcutta, Dr. Agarwal, he had, he conducts this cardio metabolic conferences in cancer. And even in that conference, we realized that usage of atorvastatin with the anthracyclines in breast cancer somehow interestingly did not give that kind of statistical benefit. In lymphomas, the statistic benefit was seen, but not in breast cancer. I do not know the exact reason. I can get back to you henceforth.
Yeah. And one probably question when we are discussing toxicity, bleomycin, unfortunately, we had one more recent patient who had bleomycin toxin and we lost her. Any practice of how do you give bleomycin? Do you give it a long infusion, prolonged infusion, or do you use steroid prior to that? Because there have been some discussions going on. Probably that would be one way to reduce the toxicity. We try to keep looking actively, but sometimes even despite that, this was post-treatment, she came with 2 months later toxicity. So that is why.
I will ask the panelists to first answer, and I will take I'll answer it towards the end. Dr. Vijit, you have anything to say about this?
So boluses we avoid. We give as a 15 minutes infusion. That is something what we do. Steroid specifically for this we don't do. We do a PFT DLCO baseline, and we kind of proactively ask the patient if they're developing a cough, dry cough specifically. So, and this is something which we do proactively to look for bleomycin toxicity. But to prolong, to avoid it altogether, I'm not giving any extra steroid pre-medication. Maybe if we pick it up early, we would start steroid as a rescue medication. But we are not doing anything preemptively for this as of now.
Naveen, any thoughts from you about this?
This one Rathel study, which was quoted previously, if there is Sierra or something, I usually don't add bleomycin from the third cycle onwards.
Okay.
Adding to what Dr. Vijit had said.
Okay. Dr. Abhay, any thoughts on this? Because this is something which is very relevant. I know we have discussed it time and again, but we need to discuss this point.
So I give around 30 to 60-minute infusion. And every time we'll check respiratory rate, oxygen saturation. Anything more less than 94, I probably suspect strongly. And also baseline, when we do PET CT scan, I look lungs, how the lungs, any interstitial infiltrate, anything is there. And also proactively ask about breathing difficulty. So any tiredness, weakness, too much tiredness, weakness after walking even short distance. So like proactively we ask only questions, and main oxygen saturation I give more importance.
That's actually very well summarized by Dr. Abhay. So one point is that we are doing the staircase walking, 1 floor, 2 floor test, and then we're doing the DLCO. I think one very important thing is we definitely have to keep monitoring that. We have to keep proactively asking our patients. Sometimes they may not have cough, but they may have low saturation, or they may have increased dyspnea on exertion. So all these points are very important. And when we do a PET scan, we can obviously get to know whether the lung parenchyma is normal or not. One thing that we all learned when you're doing our training is once you start, you also watch out for if there are striae or the bleomycin induced skin toxicity, because from whatever theory we know, it seems to predate sometimes. So not always, but sometimes it can predate the lung toxicity. But most important, like I said, is very close monitoring. We should ideally not lose patients to bleomycin. We need to be very, very careful. So I'll ask this question to Dr. Vijay. How would you treat this patient if this patient's age was more than 60? This
So,
patient is 49 years old. Would your
yeah.
treatment change?
Yeah, so we are concerned about the peripheral neuropathy and Also, the glioma and lung toxicity, actually, the same kind of risk exists even with brentuximab. So, we were just discussing some time back about the incorporation of Nivo ABD in elderly. So, if that was possible, probably Nivo ABD is something I would do. Yeah, so yeah, bleomycin and brentuximab both can cause pulmonary toxicity. So, probably I would look at Nivo ABD.
So if this 60-year-old patient did not have diabetes and had no baseline neuropathy,
If he
would
had
you
no
still
baseline
avoid
neuropathy, he was a
brentuximab?
fit. No, I would. No, then I would not. Then I would not. If someone had, if someone had baseline neuropathy and diabetes, only then I would think about that Nivo AVD. Otherwise, yeah, brentuximab is a good combination.
Yeah, so basically what Dr. Vijit wants to summarize is, if it's more than 60, do not give up on brentuximab. It will still work excellent in those patients, but they should not be having a baseline peripheral neuropathy, and that has to be very clearly evaluated. But if they don't have baseline neuropathy and their diabetes is in good control, it is still a very good molecule. We should encourage using it because of the long data that we have. So the treatment options that would be considered in this setting would be ABVD or brentuximab vedotin plus AVD. Anybody wants to change their thoughts? I mean, I put this because this patient was treated some time ago. But Dr. Naveen, would you like to change or add a new option from the options that I've discussed with the patient earlier?
The patient is less than 60 and IPS is also around 4. This one BRICAD can also be an option in this patient if he's treated this one. Well treated, I feel.
So BRICAD is your option. Have you had the opportunity of using BRICAD?
No.
Anybody in the panel has had an opportunity of using BRICAD?
No, I haven't used.
Okay.
Not yet.
So yeah, it seems a very interesting regimen. I mean, there was a comparison we all know about in the HT21 trial where they compared BRICAD to BCOP, and they did find that it was slightly more better tolerated, and that's something also I think a lot of us. But does the data encourage you to use it regularly in your practice, Dr. Hemant?
The data is interesting, but it is quite significant amount of drugs, slightly more complicated than what we have. Toxicity is definitely of a concern. You have pretty good regimens otherwise, so I not really sure where probably I would place it.
So I just wanted to just put a little.
I feel that this BRICAD option only see whenever there is afferent disease is there, now we have ABVD is there and AVD is there, BVAVD is there. So only in when we give ABVD, when there is a still we have we don't get DAVLs 1 to 3 patients will be having still DAVLs for PET CT positive. In such situation, I think in the form of escalation we may probably use. I think that is the only scenario we may probably.
So, Dr. Mangesh, Vijit here. So, probably BRICAD we could consider in this patient who's a 49-year-old or a 47-year-old,
Yeah.
in whom fertility preservation is of quite a concern. So
Okay.
that is one situation where the gonadal toxicity is much lesser at BRICAD compared to escalated BFOP. If the patient had a interim PET showing a dual score of 3 and above, and where we would want to use a escalated BFOP otherwise. So in that situation, probably BRICAD is one thing which probably in this is the right patient where we could give a escalated and BRICAD instead of escalated BFOP if the interim PET was positive. So that's the only
Absolutely.
situation where we would give. Otherwise,
Absolutely.
probably no.
Absolutely. So this is something that I wanted to discuss, and thanks, Dr. Vijit, for telling this. Is that this is where that you could probably look at BRICAD. It's a stage 4B patient, 49, younger, no comorbidities. Of course, fertility preservation is an added advantage, but it doesn't hurt for us to be aggressive with these patients because we should be aiming for a very good 5-year overall survival. Try to as much as possible reduce the relapse. The relapse-free survival of BRICAD is quite good. So I think that's a very good option that we can offer our patients today, that we can offer along with BRICAD, we can offer. So between BRICAD and brentuximab AVD, which one would you prefer, Dr. Vijay? Just to, you must have used brentuximab with AVD, but how do you score BRICAD over that regimen? Because
So I don't
both of
think
them have data for the advanced disease.
Yes, I don't think there's any head-to-head comparison over there. But purely from the response rate, probably we'll be looking at brentuximab vedotin. But in that situation where we had interim PET, we had data to kind of lean on BRICAD. So from that perspective, probably BRICAD, where gonadal toxicity is something you're worried about, and if the patient is worried about peripheral neuropathy and things like that. But otherwise, yes, just choosing, just to answer your question, probably I would choose brentuximab.
Fantastic. So just wanted to drive home the point that even if you just use brentuximab with AVD, your overall survival data
Sorry,
is
sir.
yes.
Dr. Mangesh, sir, sir, request you to conclude the session as we are
Yeah, I'll be
near
done.
the
I'll be
end
done.
time.
Another three,
Yeah,
4 points. Yeah, 3, 4
sorry,
slides.
sorry, sir.
So the overall survival at 7 years is more than 90%. It's really hard to neglect this kind of data, and I think definitely it is one of at the forefront of what we do. If given a choice, I know there is a lot of controversy about what to use first, immune checkpoint inhibitors versus this, but the data of 7 years overall survival of 93.5 is absolutely difficult for us to. We have seen all and done all when it comes to the brentuximab. We have, irrespective of how many patients we have used, we all conclude from north to south and east to west of our country that in the right patients at the first line attempt, brentuximab definitely gives a lot of importance. So just wanted to put across just one of the study that I wanted to discuss with you is the controversy or the thought process about would you like to go for nivolumab or brentuximab first. So I will just sit on the slide because we can have a discussion. So this was a very seminal study. We don't get to see this kind of comparisons that are done in our in trials. We usually have we end up making cross trial comparison, but this is a wonderful study. I mean, we all are aware that this was done in both pediatric and adult advanced Hodgkin's lymphoma. Nivolumab plus AVD versus brentuximab plus AVD, all both are 6 cycles. Huge number of patients, 470 patients is not hard to get. And at the end of 1 year, the PFS was 94% versus 86%. 2 year PFS is also very encouraging, 92 versus 83%. And at a recent report with longer follow-up of 2 years, it shows improved survival for older patients receiving NAVD. Just wanted to put across between my panelists here, I'll have one statement from each of you, starting with Dr. Naveen. Dr. Naveen, with looking at this data, on one hand, you have a 2 years follow-up of nivolumab versus brentuximab. On the other hand, you have the data of Echelon 1 study where they have seen 7 year overall survival benefit. What are you leaning towards? Let's not worry about neuropathy. Let's not worry about other adverse effects. I'm sure a lot of us understand where to use and where not to use and how to manage that. What is your leaning now?
This NAVD has shown better superior PFS than BVABD with a HR of 0.48, which is very significant, even though it is this a 2 year follow-up, and it is better tolerated, and there is a lower treatment discontinuation and lower immune-related adverse effect compared to BVABD. And going forward, it looks like NAVD is going to become the new standard of care in case of advanced Hodgkin's lymphoma. This is what I feel.
The fair point, fair point. What about Dr. Abhay? What do you think?
Fairly done study, and there's a PFS benefit in the nivolumab arm. And even though it is very short duration, but the tolerance is much better compared with BVABD. And also the toxicities. We all know that. So somebody immunotherapy, the response will be maintained for longer period of time. So I think going to be the future category.
What about Dr.
As of now, it's
Hemant?
not.
When the initial data of single arm Nivo AVD came, I had a 70-year-old lady whom I ended up using Nivo AVD. This was even before this trial data was out. She had excellent response. She went into CR, but now at the end of 2 years, she's got a relapse. So definitely, I think overall, based on the trial data, this looks like a very good option. But sometimes you have a good longer follow-up data of Echelon 1. Very difficult to incline towards which arm. Tolerance-wise, definitely Nivo AVD would be something that I'm comfortable. Also, at the same time, I've used nivolumab or immunotherapy, even low-dose nivolumab and multiply relapsed Hodgkin lymphomas, and they've been going on for years together. So it is definitely a lymphoma which responds extremely well to immunotherapy, but I've got a patient whom I've treated with the same protocol, but I had a relapse at the end of 2 years. So one of
I will ask a different question to Dr. Vijit. There is some talk about combining Nivo and brentuximab in the first
Brentuximab,
line.
yeah.
So what are your thoughts on this? Because I thought I leave
No, the toxicity is pretty high, I think.
leave the most futuristic question to you.
No, actually, that I had put up in the last slide. Actually, I think you missed
Mm.
that. So in
Mm.
that, it showed pretty high toxicity. Actually, grade 3 toxicities are very high in that group.
Mm.
So they have even gone on to the extent of there's a phase 2 data where they're combining Nivo, brentuximab, and eldriamycin and dacarbazine. So they are that ambitious, and I think the toxicity is pretty nasty with that. But yes, I think there may be cases where you would choose a milder chemo combination with that, probably dacarbazine, brentuximab plus nivo, something like that may come in the future. So yeah, all these combinations will be tried at some point of time, I'm sure. So it's only more exciting as we head into this, and also the ctDNA and the MRD and the immune environment being looked into. I think I'm sure it's going to get more difficult for us to choose the therapy. So maybe we'll be spoiled for choice and regimens.
I think one thing that it might do after we learn that it's more toxic is probably we can take off adriamycin. Maybe look at like just now how we are looking at different cancers without anthracyclines. Maybe this we could explore that, because that is one commentary that I read, that maybe if we lose the adriamycin, we are probably going to get a good result with the reduced toxicity. But again, like I said, it's something in the horizon. We don't know how much to look at, but definitely an interesting space. Now, in the case of Hodgkin's lymphoma, with such great survival results, now we are in the mode of Dil Mange More. We want to get better and better results than what we have. Even a 2 or 3% results with large number of patients seems to give a statistical significance. But our patients are to benefit because of all these options. So thank you very much, my esteemed panelists. Wonderful discussions, and I learned a lot from you. I hope the audience did too. And thank you, Dr. Rachan, for making me the moderator for this session. And back to you, host.
Thank you, Mangesh. It was a very well moderated decision.
Thank you so much. Thank you. Thank you.
Yeah, Mangesh has always has moderate sessions really well, and we learned a lot of new things from this discussion. So we end this Hodgkin lymphoma session, and next we will start with the diffuse large B-cell lymphoma session, which is sponsored by Roche. For this session, for the first talk, which is about polatuzumab vedotin in previously untreated DLBCLs, I would like to welcome Dr. Vishwanath, who is one of the persons responsible for this meeting today. And I'd like to welcome Dr. Vishwanath, who is a senior consultant medical oncologist and academic advisor at Apollo Hospital, Bangalore, and a fellow of MD Anderson lymphoma myeloma fellow. Thank you. Over to Dr. Vishwanath.
Yeah, thank you so much, Dr. Rachan, and thanks for that introduction, and thank you Horizon Group for hosting this wonderful webinar. And after that wonderful discussion on Hodgkin lymphoma, let us shift gears and once again. Let us shift gears and move on to DLBCL. And now we have seen that there are a plethora of new drugs in diffuse large B-cell lymphoma space as well. So today I'm going to talk to you all about this polatuzumab vedotin in previously untreated diffuse large B-cell lymphoma. There's a disclaimer. The slides are provided by Roche Pharmaceuticals. So DLBCL we know is one of the most common non-Hodgkin lymphomas, and we do know that 30% of patients with are diffuse large B-cell lymphoma amongst all the B-cell lymphomas. And if you see broadly, lymphoma per se, 30% is Hodgkin, 70% is non-Hodgkin, and B-cell lymphomas is 85%, and then around 35 to 40% is DLBCL, follicular is around 10 to 11%, SLL is 6%, and then we have the minority, which is the T cell and NK cell lymphomas, which is around 15%, of which PTCL, ALK positive, ALCL comprise a small percentage, and then the rest of it could be extranodal NK T cell lymphoma and the rest. So, likelihood of cure is highest in treatment in the first line setting, just like any other condition. And the first line treatment for diffuse large B cell lymphoma may also involve CNS prophylaxis and radiation in select cases. And we do know that 40% of the patients with 60% of them get wonderfully treated with the conventional R-CHOP and are progression free and may have a cure. And once they have a cure, they have a life expectancy which is similar to age and sex matched cohort control. And unfortunately, 40% of them do not get cured with conventional treatments, and they have a disease progression, and in which case only select patients are eligible for to receive CAR T cell therapy because of various reasons, including the patient eligibility and of course the cost factor and other logistics, and including some patients are eligible for stem cell transplantation as well. But if you see in second line treatment with CAR T, you can get up to 20% cure of all the second line DLBCLs, and with auto transplants around 5% of all second line DLBCLs. And if the patients do respond and they get cured, approximately 25% reach that curative level. But if you see rest of them, again the non-responders, and then that which comprise around 75% of all the second line, and then if they progress after first line, 35% of them after with progression after first line therapy, and then you give second subsequent therapies, and then most of them don't get cured, but we could probably control the disease and move on. So if you see, we have come a long way, but if you see the standard of care over decades has been mainly the CHOP, and then we had this wonderful drug, the CD20 antibody, which initially came in 1997, and then the R-CHOP, the standard of care since 2002, and since then we've been doing this R-CHOP, R-CHOP, R-CHOP for quite some time, and now we are seeing some change in the treatment of diffuse large B-cell lymphoma. So R-CHOP does not cure many DLBCL subgroups. We discussed about that. So patients with low IPI, early stage disease have a high chance of cure. GCB, yes, to a large extent, but sometimes we've seen that GCBs do have a double hit lymphoma, which is more common in double GCB phenotype, and those patients may not do that well. And we do know that high IPI, age more than 60 years, non-GCB phenotype, those who have this double expression or triple expression, where this MYC and BCL2 expression, or MYC BCL2 BCL6 co-expression, which is called triple expressor, or if they have this double hit lymphoma, the chances of cure is much lower. We have a plethora of drugs now targeting several receptors, and we have so many targets, bispecific antibodies, and then we have LEN, which has been going on for quite some time, and then the PD-1 inhibitors, though more with Hodgkin, but there is also some growing data in DLBCL as well, bortezomib, venetoclax, um, loncastuximab, and then we have mosunetuzumab, we have polatuzumab, which we are going to discuss, and we do use acalabrutinib a lot, BTK inhibitors, and ibrutinib as well, the prototype drug, and tafasitamab has been used along with lenalidomide. So all these new drugs have shown some promise in patients with relapsed diffuse large B-cell lymphoma. So if you see, several studies have tried to optimize the treatment in R-CHOP, and if you see the initial the Goya trial looked at R-CHOP versus G-CHOP, which is so that was combining obinutuzumab with CHOP versus R-CHOP. That was they not statistically significant. And then we have the robust trial which looked at R square CHOP versus R-CHOP. We do know that the phase 2 trial with Greg Nowakowski, which showed that ABC subtype patients did better with adding lenalidomide, but the phase 3 study was not showing statistical significance. And then we have the addition of bortezomib to R-CHOP versus R-CHOP, again not statistically significant. Ibrutinib plus R-CHOP versus R-CHOP. We saw that the EFS of the hazard ratio was 0.93, again not statistically significant, but it did improve in a select subset of patients who are less than 60 years of age. And then they also tried adding bevacizumab plus R-CHOP, again not statistically significant. And then we have the URTC trial looking at gemcitabine plus R-CHOP, again early closure due to DLT. And then dose adjusted epoch which came in with lot of promise, and we still use that in certain select high risk patients. But if you see the SWOG, the CalGB 50303, was not statistically significant and also led to more toxicity with dose-adjusted epochar. And then the dose intensified regimen of comparing RCHOP 21 versus 14 was again not statistically significant. And then several maintenance therapy has also been tried, but nothing has actually changed the landscape until these new drugs have come into picture. So, Pola RCHP is the only regimen approved in the last 20 years which has improved treatment outcomes in the first line diffuse large B-cell lymphoma. We started with CHOP, and since 1997, which rituximab came into picture, and then RCHOP in 2002. And for two long decades, we've been using mainly this particular regimen. And then the Pola RCHP has actually significantly changing and the paradigm. So polatuzumab vedotin, it's an antibody drug conjugate targeting the CD79B, which is a signaling component of the B cell antigen receptor complex that is ubiquitously expressed in patients with diffuse large B cell lymphoma. And polatuzumab vedotin consists of a potent microtubule inhibitor, which is the MMAE, conjugated to the CD79B monoclonal antibody via a protease cleavable peptide linker. It's basically an ADC. So this particular study, which was a global randomized double-blind placebo-controlled trial, the POLARIX trial, it was published in the New England Journal of Medicine. And we do know that over a period of time, I'm sure polatuzumab is replacing, I would say, vincristine, and or maybe with a lesser toxicity as well. So let's talk about the POLARIX trial, which is a phase 3 study evaluating POLA's RCHP versus RCHOP in first-line diffuse large B-cell lymphoma, global randomized double-blind placebo-controlled trial, and patients with untreated diffuse large B-cell lymphoma, 18 to 80 years of age, IPA of 2 to 5, and ECOG performance status of 0 to 2. Good number of patients, 879, randomized at 1:1 ratio. In the first arm, it was polatuzumab plus CHP plus vincristine placebo, the usual 21-day cycle times 6 cycles, 440 patients, and the usual dose of 1.8 milligrams per kg body weight. And the other arm was RCHOP plus polatuzumab placebo, and again 21-day cycle times 6 cycles, and they were both well matched, 440, 439 patients. And both the arms, there was a single agent rituximab which was given in cycle 7 and cycle 8. And the primary endpoint was PFS by investigator, and the secondary endpoints included EFS by investigator, PET-CR at the end of treatment by blinded independent central review, overall survival, and safety. So if you see the baseline characteristics, very well matched. If you see the median age was around 65 to 66 years, around 50 to 54% of the patients were males, and most of them had a 0 to 1 performance status. And if you see the IPI 3 to 5 was around 2/3 of the patients, and around 43% of the patients had a bulky disease, and 2/3 of the patients had high LDH, and stage 3, stage 4 in a predominant number of patients, and around 50% of the patients had 2 or more extranodal site involvement. And if you see here, this is important to note that DLBCL, NOS, ABC, and GCB comprise around 84% of the patients, and the cell of origin by the nanode string, GCB in 55%, ABC in 30%, and unclassifiable in around 15% of the patients, which was again well matched in both the cohorts. So if you see the POLARIX trial, it met its primary endpoint of progression-free survival. And at 24 months, we have a 6.5% additional progression-free survival as compared to with Pola RCHP as compared to RCHOP, and beating RCHOP at 2 years with demonstrating a 27% reduction in the relative risk of disease progression, relapse, or death is significant, because we have seen that over last 2 decades, RCHOP has stood the test of time. And 24-month PFS of 76.7% with Pola RCHP versus 70.2% with RCHOP, 6.5% at 2 years is quite significant. So Pola RCHP is the only regimen approved in the last 20 years that has improved treatment outcomes, as mentioned before, in the first line treatment. And the 6.5% additional advantage of the PFS and the hazard ratio of 0.73. So one of the important endpoints is also PET CR at the end of treatment. And if you see here, that was also better in patients who had in the polatuzumab arm by around 4%. and that also translated into disease-free survival with a hazard ratio of 0.7. So again, one of the important characteristics is the GCB versus non-GCB. If you see here clearly, ABC patients did significantly well with a hazard ratio of 0.34, which is phenomenal favoring the polatuzumab arm. GCB, you're seeing a hazard ratio of 1.03, not showing much statistical significance. And if you see the hazard ratio is also crossing 1 and a very wide confidence interval and very similar situation even in unclassified. So ABC patients did much better. Then they also looked at this dark zone signature positive patients who do relatively badly. But if you see here, the patients with dark zone signature positive DLBCL who had GCB DLBCL and represented the majority of the high risk double hit lymphoma and triple hit lymphoma had a better potential outcome when receiving Pola R-CHP versus R-CHOP. So this is basically going one step further to do the gene signature. So the PFS was improved with Pola R-CHP versus R-CHOP in elderly patients as well. And you can see here this separation of the Kaplan-Meier curves and the hazard ratio of 0.64 and the p-value which was also significant. And the OS also, if you see, the hazard ratio was 0.74, but it was not statistically significant. But we are seeing a good PFS benefit in patients who are even elderly. The overall survival analysis, so at a median follow-up of 39.7 months, the hazard ratio of 0.94 and the p-value was 0.73 and again not statistically significant. Maybe we will have to wait for some more time to see that OS advantage, especially to beat R-CHOP. So patients with who received the polatuzumab arm required less subsequent lymphoma therapies. If you see here, the blue one is R-CHOP and the green one is Pola R-CHP. And if you see here subsequent therapy, any treatment including radiation, other systemic therapies, stem cell transplant and CAR-T were lesser as compared to the R-CHOP arm. This signifying that these patients probably have a better progression-free survival and better outcome as compared to R-CHOP. This was the other study which was presented in ASH 2024. It was a 5-year analysis of the Polaric study. Prolonged follow-up confirms positive impact of this particular drug as in addition to our CHUP on outcomes. So we know the Polaric's design and the global population. If you see, we have discussed all this, and the progression-free survival was median progression-free survival follow-up was 54.9 months, and the median OS follow-up was 64.1 months. And if you see here, the initial PFS benefit of Pola R-CHP over R-CHOP is maintained at 5 years. We looked at the 2-year initially. Now, if you see at 5 years, you're still able to maintain that close to 5% additional advantage. And if you see here, the hazard ratio is also quite significant at 0.77. And the other aspect is the duration of complete response, which is also important. And if you see here, that also the hazard ratio is maintained at 0.75. And this again goes to say that the complete remissions are durable and sustained with longer follow-up. This is very typical of even in CAR-T, the ZUMA-1 trial. Patients who had a CR at 3 months went on to have a longer overall survival. So if you see here, the duration of complete response is also important. And patients treated with Pola R-CHP required 23% fewer subsequent therapies versus treatment with R-CHOP. Again, if you see the intent to treat population, the new onset therapy and then radiation, other systemic therapy, platinum-based therapy, everything was actually more in patients who received R-CHOP. Again, this mirrors the routine clinical care at the time of study conduct. So the 5-year overall survival shows favorable results for Pola R-CHP treated patients. If you see here, the hazard ratio was 0.85. So at 5-year follow-up, numerically fewer deaths were observed in the Pola R-CHP versus R-CHOP arm with a hazard ratio of 0.85. Though, of course, early days, I mean, I don't think we can draw too much conclusions with the overall survival. If you see here, the confidence interval is a little wide. So this is a study by Dr. Reena Nair, which looking at the DLBCL outcomes in India. Good number of patients, 1,365, multi-center, real-world prospective observational study in newly diagnosed patients with DLBCL who were treated with R-CHOP. The best overall response rate at 6 months was 90%. 2-year PFS was 69%, and 2-year OS was 79%. And they also did a multivariate analysis. They looked at BCL2 expression and the basically the quality of life, which was prognostic. Again, favorable prognosis was basically seen in patients who had an early stage disease. And again, the cell of origin was also important. Those who did not have a BCL2, no extranodal disease, low IPI, and those who had a good quality of life questionnaire, and then age less than 60 years, and ECOG performance status of which was good. So deaths associated with lymphoma progression are numerically fewer with polar R-CHP versus R-CHOP in the global population, as seen here. And if you see the 5-year PFS and OS outcomes show consistent treatment effects of polar R-CHP across subgroups in the global population, including the age. If you see the hazards here, including the age, the IPI score, those who had bulky disease, probably the hazard is a little crossing the midline. And certain other situations like GCP, it is crossing the midline, and those who are unclassified, again crossing the midline. Apart from certain and triple hit lymphoma and all certain situations, but other than that, I think the PFS and OS by subgroups, including high risk groups, generally favored the polar RCHP. But in certain situations, it was probably crossing the midline. But otherwise, in most situations, it was beneficial. The Polarix expanded population included a total of 1,000 patients. And if you see here, since 2017 till now, it also included some patients from China. So with the addition of the China extension cohort, distribution of patient characteristics was not modified. And if you see here, the efficacy outcomes in the expanded population are similar to the global population. And this, again, the overall survival, if you see the hazard is 0.83. But like I said, with the PFS, definitely yes, but the OS, we'll have to wait and see what's going to happen. But at least the PFS benefit, it has beaten R-CHOP. So competing risk analysis for deaths in the expanded population. So the probability of lymphoma-related deaths was again higher at 5 years due to R-CHOP, and non-lymphoma-related deaths were more or less similar. So polar RCHP showed a favorable benefit risk profile as compared to R-CHOP in the expanded population as well. If you see the grade 3 or more adverse effects, more or less similar. And so safety profile remained comparable between the treatment arms with no increased risk of long-term follow-up, and there was no substantial change in the proportion of patients with adverse effects, that is 5% or more as compared with the global population. This again just goes to say neuropathy is an important thing with the antibody drug conjugates as well as vincristine. It was not relatively higher, and neutropenia is also an important thing, again not very high as compared to the other arm, and the infections also and cardiac arrhythmias were in minority. So to conclude, the 5-year extended follow-up of Polarix showed consistently sustained and significant PFS and DFS benefits for patients receiving the polatuzumab plus rituximab plus CHP versus R-CHOP, and fewer subsequent anti-lymphoma treatments were needed with polar R-CHP versus R-CHOP. Numerically fewer deaths, especially lymphoma-related deaths, were observed in patients with polar R-CHP as compared with R-CHOP, and favorable outcomes were seen in polar R-CHP across exploratory subgroups, but cautious interpretation is advised. And the safety profile remained similar between arms, and no new safety signals were noted. And the 5-year data confirms that this particular combination is a standard of care for patients with previously untreated intermediate or high risk diffuse large B cell lymphoma. I would say specifically for the ABC subtype, where you have seen significant improvement and also the separation of Kaplan-Meier curves, and prolonged follow-up of Polarix is planned. And this is the NCCN guidelines. We're seeing that polar CHP is figuring in all these situations, including the patients who are having the stage 1, stage 2 with extensive mesenteric disease, with eccentric mesentery, or even stage 3, stage 4. So it's there. So the impact of Polarix, it's the first trial in the last 2 decades to show a meaningful improvement in the benefit risk profile for over R-CHOP in an international phase 3 double-blind randomized control trial. Long-term follow-up analysis of the Polarix study confirms an ongoing and encouraging PFS benefit and indicates a positive trend in OS in favor of the polatuzumab arm. The benefit of Pola-R-CHP holds even more importance in settings with limited availability and access to efficacious treatments in relapsed and refractory diffuse large B-cell lymphoma. And the Pola-R-CHP is a category 1 preferred regimen as per the NCCN guidelines and also recommended by the NICE guidelines. Thank you so much for the patient listening, and thank you so much, Dr. Rachan, for the opportunity.
Has always a very good presentation by Dr. Vishwanath. And after concluding this talk, we will go over to the next presenter, Dr. Anand Pai, Professor and HOD of Department of Medical Oncology, who will be talking about relapsed refractory DLBCL, CAR T cells, bispecifics, and novel antibody drug conjugates. Over to Dr. Anand Pai.
At the outset, I thank Dr. Rajan and the organizers for the opportunity. Can Aditya please share my slides? Yeah, the topic that I'm dealing today is a little different in terms of that it's a broad outline of what we would do in a relapsed refractory setting. So we know that a lot of DLBCL present in advanced stage with yeah, can you make it full screen and leave the couple of slides of disclaimer and then go to the presentation? Yeah, the next slide, please. No, the previous slide. The previous slide. First slide, please. I think you're missing a slide here. Can you just go to next slide? Yeah, go to the next slide. Okay, all right, no problem. Right, so I hope you're sharing the slides that I've sent you, Aditya. So over 1/3 of the patients have got refractory disease or relapse after first-line treatment. We are aware of that, and options in this subset includes CAR T cell therapy or combination therapy and transplant as one of the options. Next slide. Yeah, Aditya, you're not sharing the slides that I've sent you. You're sharing another slide set. Can you please share those slides which I've sent you?
Just give me a moment, sir. Just 1 minute.
Sorry for the interruption, and we'll go ahead with the talk after some time.
Aditya, this is not the slide set because I've written the date. This is not the slide set. I've mailed it to you. Please don't.
Just a second, sir. Sorry for the interruption.
Yeah, can you make it full screen? Yeah, next slide. Yeah. So, yeah, so we know that 30 to 40% of the patients have got relapsed, a chance for relapse. Next slide. So, what does the relapse look over time? If you look at the probability of first remission, first relapse, and the second relapse, a lot of relapse happens in the first 2 years, about 72%, which eventually decreases. And 44% of these patients tend to respond to salvage therapy. This is as per the Swedish registry study. But what is more important is, next slide, for us to understand who's at risk for relapse after first line of therapy. If you look at this patient-specific and clinical factors on the probability and duration of remission, if you look at the sex-wise stage, PS, serum LDH, extranodal, and IPI, definitely a lot of advanced stages, poorer PFS, and a lot of extranodal disease, higher IPI. These people have got a tendency for being in lesser in remission and achieving remission. Also, there's a tendency to have lesser remission. Next slide. So stratified by the age-estimated IPI at the start of second-line therapy, we know that patients with low risk will definitely tend to do better, but those with high risk again will not do better, which means to go on to say that IPI still has got a validation even in probably in second line as well, even though we may not focus much on that. Next slide. And poorer survival is there across refractory DLBC subgroups, whether it is primary refractory or refractory to second line or later, or whether patients have relapsed after transplant. And if you look at the median months from commencement of therapy, it is roughly about 6 to 7 months that they would achieve survival, PFS survival. Next slide. Early relapse is associated with poorer survival, and clearly you can see that patients who relapse later will probably do better than early relapses, and patients who relapse within 1 year would probably not do well compared to patients who would relapse after 1 year. Next slide. So if you look at the historic paradigm for treatment, I think so. We all knew that patients, if relapse, would probably be divided into fit for therapy or not fit for therapy, and we would probably try to give them salvage therapy and take them up for transplant. And those wherein we would not achieve a response or would not be fit for therapy, we would give palliative chemotherapy. But I believe a lot of that has changed now. Next slide. So, like I mentioned, historically, transplant has improved outcomes in relapsed refractory DLBCL, and we know that patients who are in CR would tend to do better, and patients who would go on to receive transplant would definitely do much better than patients who would not have undergone transplant. But let's look at how these newer therapies have impacted the relapse and refractory setting. Next slide. The standard of care has always been the chemotherapy that we were all using, probably RICE, RDAP, RGDP. But all of these underperform in the present modern era with newer treatment modalities being available. But a lot of these patients may not be eligible for the newer ADC or CAR-Ts and all, which I'm going to talk. So this still may represent a large treatment option for the patients whom we are treating in our real world. Next slide. So when they looked at pooled analysis of all these phase 3 trials and observational cohorts, you can actually see that whether patients are primarily refractory or those who relapse, the median OS is just about 6.3 months, with the response rates harboring around 20 to 30%, which is really dismal. And definitely there's an unmet need to improve this. Next slide. So let's look at the current DLBCL treatment landscape. So like usual, if someone has relapsed poly, we would look at whether patients are eligible for CAR-T or transplant. That is the probably way forward that we're going to look upon. And what is seen in the right, in the center, in the box there is what probably we would all do in our routine practice. Third line and beyond is what recent advances is all about. And probably as more and more people can afford CAR-T and transplant and then relapse again, maybe we'll be using this third line therapies as well. Next slide. So this is a simple algorithm for the management of first relapse of DLBCL. If the relapse is less than 12 months or it's a primary refractory disease, the first question that we would ask is whether the patient is eligible for CAR-T therapy or whether the patient would be taken up for salvage therapy. If CAR-T therapy is not an option, we would probably treat them with salvage chemotherapy and try to consult it with transplant. But when to use CAR-T in second line setting? Yes, fit patients who would otherwise be eligible for transplant. Primary refractory or less than 12 months is an ideal subgroup. But the choice of product depends on pheresis slot availability and a lot of other factors. So it is important for us to understand that we need to sequence the therapy right at the beginning of the first relapse. Next slide. So the big game changer has been the CD19 targeted CAR T cell therapy, and this is the second line therapy for large B cell lymphoma at this point of time. Time from first line therapy, if it is less than 1 year, which forms probably 75% of the relapsed refractory subgroup that we look upon. If they are eligible for CAR T cell therapy, second line CAR T cell therapy is an option, which probably is 70% of the patient population. And about 30 to 40% of these patients tend to do well, and a projected cure rate is about 20%. Whereas in case if they are more than 1 year and if they are eligible for transplant, we would probably give them second line salvage and consolidate with transplant, wherein which probably 40 to 50% of the patients will undertake, but the cure rates would probably be only 5%. Now let's look at someone not eligible for a CAR-T or for a transplant, which probably forms about 30% of CAR-T and 50% of those patients who relapse after a year. These patients would probably be treated with further immunotherapy or the ADCs or newer modalities. Next slide. So let's look at CAR-T now. Next slide. Yeah, the next slide. Yeah, so we know the concept of CAR-T. There's a collection, manufacturing, infusion, and activity. I'm not going to go into the depth of this, but let's look at the trials that are involved in DLBCL. Next slide. So this slide depicts all the trials that have been used in DLBCL relapsed refractory setting, the Axical, the Tisacel, Lisocell, and the three different trials for that. What is more important to notice in this slide is that all these patients were probably relapsed refractory and high risk, and primary refractory or relapsed within a year, and probably ineligible or post transplant. And the overall response rates are to the tune of about 80% in 70 to 80%, with CR being achieved in more than about 40-50% of the patients. That is quite a good number, because this probably tends to improve their quality and technically the quantity of life as well. So if you look at the survival, the 12-month PFS and OS rates are also in the tune of 50%, which is fairly well, because otherwise the cure rates with salvage therapy would probably be less than 20% at 1 year, and probably 5 years it would be less than 5%. Next slide. So the slide that I'm showing now depicts actually the survival with anti-CD19 CAR T cell therapies in the various trials that are listed. And if you can actually look, probably those patients who would do well at 1 year probably would still do well after that. At least the slide shows about 3 years plus. So if you look at the trials in depth, next slide. The Zuma, the Belinda, and the Transform, these are the three different trials involving the three different drugs there. Let's look at some of them. Next slide. So the Transform subgroup analysis, which looked at the Lisocell versus the standard of care in relapsed refractory. On the left-hand side, you can look at those with primary refractory, and on the right-hand side, you can see the early relapse. And compared to the standard of care, if you look at the OS, the 12-month EFS and the 18-month EFS along with OS, it is about 80% versus 60% at 12 months, 68 versus 55 at 18 months, and an overall survival of 29.5 versus 20.9. And on those patients with early relapse, again at 12 months, it is 91 versus 86. And an 18-month EFS is about 87 versus 75, and the OS had not reached way back in 2023 when this was presented. So definitely, LISO compared to the standard of care had a better OS and EFS in this study. Next slide. So when they looked at the Zuma and the Belinda also, again, you can actually look, the standard of care actually involved platinum-based chemotherapy that was given as salvage chemotherapy. So the median AFS improved from 2 to 8.3 for this in the Zuma trial for the axis cell, and EFS at 2 year of 41 versus 16, with a CR of about 65 versus 32. And the 48 month, that is 4 year OS rates were 54.6 versus 46. 36% of the patient population actually took it as a bridging therapy for transplant. So that's also important that, this could be used as a bridging therapy. In the Belinda, where the TISA cell was compared against the standard of care, the ORR rates and the CR rates were definitely better compared to the standard of care. Next slide. Again, this was the Zuma which showed the EFS and the OS benefit. 10.8 month EFS versus 2.3, and median OS of not reached at 4 year. 4 year rate of OS of 55% versus 46% for the comparator standard of care, and a median OS of 31 months versus not reached for the axis cell. The transform trial, next slide. So the transform trial actually also showed a EFS and a OS benefit. You can see 2.4 versus 29.5 months for the LISO cell, and the OS was also at least till the third year was the curves were wide apart. However, CRS and neurotoxicity rates are present, but we need to remember what is more than grade 3 and how it was managed. Next slide. The next couple of slides probably show similarly benefit for liso-cel, which was the pilot study, which showed that patients with who had received liso-cel compared to the standard of care in transplant ineligible patients, the EFS PFS rates at 12 months and 18 months were much better in patients who had achieved CR or PR compared to the standard of care, which was 2.9 months and 1 month. Next slide. Again, the Elegant showed axis cell high anti-tumor response of 11.8 months PFS benefit in patients. This was a single-arm phase 2 study. But again, this goes on to say that probably CAR T cell makes a lot of difference when it comes to the relapsed refractory setting, especially in those patients who are refractory upfront or relapsed within 1 year. Next slide. So to look at the Indian CAR T cell programs, yes, the ImmunoAct, the telecapped gene autolysil, the CD1941BB. So 47 patients were enrolled and 36 were available for efficacy. And if you look on the right-hand side, the overall response rates, 72%. The median duration of response was 4 months, and median PFS was 4 months. The median OS was about 12 months. So now, again, this goes on to say that even in the Indian population, CAR T cell has shown a lot of promise. Next slide. Again, the Immunil CAR T, which looked at the well CAR T, the overall response rate at 365 was 50%, with a CR of about 83%. The median PFS was 9 months. So again, both these trials have actually shown that even though the numbers are smaller compared to the other trials, that CAR T cell, even in the Indian population, is making a difference in the relapsed refractory subgroup. Next slide. So just to put everything in a nutshell, how to fit CAR T cell therapy in patients with primary refractory or relapsed refractory less than 1 year, probably CAR T cell therapy would be the first choice. If not, salvage platinum chemotherapy, and in those patients who do not have a response, again attempt for a CAR T cell therapy, and those with excellent response maybe can go for transplant. And if they progress during post-transplant, take them up for CAR T cell therapy. But the key items to consider is refer patients upfront early for CAR T avoid therapies that causes severe lymphopenia, stop novel agents prior to infusion, think of bridging therapy if needed, and lower the disease burden, lower is the toxicity. So early referral will make a difference. And always rule out HIV and active infection before we decide on CAR T cell therapy. Next slide. So having looked at this, I think so we need to also look at what are the barriers, at least in the Indian setting. We need to pick patients wisely, patient eligibility. You need to look at the rapid disease kinetics. You need to also look at accessibility to treatment center, the toxicity management, the cost effectiveness, and the reimbursement sector as well before we decide on CAR T cell therapy. Next slide. Having rushed through the CAR T cell therapy, I think so. Let's look at few slides on the bispecifics. Yes, we have the epcoritamab, the glofitamab, and the odronextamab. These are bispecifics. I'm not going into the details of these bispecifics. Next slide. We are aware of the mechanisms of these bispecifics and the way they act, but at least at this point of time, there are two drugs which have got accelerated approval, and then there are a lot of drugs which are in pipeline yet to come and get approval. So let's look at the next few trials. Next slide. So the Glofit Gemox compared to Gemox, R Gemox in the relapsed refractory DLBCL after 2 years of follow-up actually showed a clear benefit for the Glofit Gemox subgroup, and this has now become one of the standard of care for relapsed refractory for not transplant eligible and not for CAR T cell therapy. Hazard ratio of zero 0.6. And the 12-month OS, 24-month OS rates of 54.4 versus 33.6. Next slide. It also, the same trial also showed a decent PFS benefit. Next slide. Yes, showed a decent PFS benefit. So if you look at the F4 NHL1, which looked at the epcoritamab, again, in this, the best response rate were of CR of 39%. And post-CAR T cell therapy, also patients had got 34% CR rates, which means probably, bispecifics can be used post CAR T also with the decent CR rates. Next slide. So also when they looked at the 12 months and 24 months OS and PFS, in those patients with CR, you could actually see that those with CR had a better response compared to those with PR, with the median PFS at 3-year follow-up of 37.3 months for PFS and not reached median OS at 3-year follow-up for epcoritamab. Next slide. So the odronextamab was another drug which was looked at relapsed refractory setting, which was the trial actually looked at different dosing, but even this drug the previous slide, yeah, showed a decent CR rates. Next slide. In patients with the transplant ineligible, the Mosun Pola PFS improved the rates versus R-GEMOX, overall response rate of 70% versus 40%, and a CRR of 51 versus 24.3%. Next slide. So the bispecific antibodies as monotherapy have demonstrated high response rate after 2 lines of therapy, whether it is the glofitamab or epcoritamab or the odronextamab, with the CRR rates of about 40%. Next slide. And after prior CAR T cell therapy, also these drugs have shown CR rates of about 30 odd percent, which means probably, when more CAR T are being offered, probably bispecifics still have a role to play. Next slide. So a number of further studies are also going on when it comes to this bispecific. Next slide. So which bispecific to choose probably between the two which are approved at this point of time? Safety and efficacy are both similar. Inpatient observation is recommended for both, but glofitamab has got a fixed duration, 21-day cycle into 12, and less frequent administration, does not require steroids for CRS mitigation, whereas epcoritamab does not require obinutuzumab for tumor volume reduction. Next slide. So those patients, how to decide for bispecific compared to other therapies? Yes, it's off-the-shelf option, which means readily available, unlike CAR-T, which needs to be prepared. Safety profile-wise, lower toxicity and risk, shorter hospitalization times, and different targets, which means again CAR-T cell therapy is not precluded, so we can use it vice versa. And the advantages over conventional chemotherapy has been that it's an improved efficacy and potentially better and improved quality of life. Next slide. So at this point of time, when you look at relapse refractory center, CAR-T exposed or not exposed is the way forward. If CAR-T exposed or ineligible, probably bispecific antibodies prior to salvage therapy would be a choice if patients are not eligible for transplant. If they are probably eligible for transplant, then we would give them salvage therapy. And if patients progress after CAR-T and then probably after bispecific, we would use salvage chemotherapies. Next slide. A quick couple of slides on the antibody drug conjugates. Yes, again, we know the mechanism for these ADCs. Next slide. The Polarago was the phase 3 trial which looked at Pola R-GemOx in patients with relapsed refractory setting. Next slide. And this trial actually showed a statistically significant and clinically meaningful benefit in terms of OS and PFS. A median PFS of 7.4 versus 2.7, with the ORR of 52.7 versus 24.6, and a median OS of 19.5 versus 12.5. So again, Pola in the relapsed refractory in transplant ineligible patient with R-GemOx showed a clinically meaningful benefit. Next slide. Pola BR is another drug regimen which has been used in the relapsed refractory setting. Next slide. And this again has showed median OS of 12.4 versus 4.5 for the BR regimen, with the ORR and the CRR rates also doubling with the incorporation of polatuzumab along with BR. Next slide. So tafasitamab with lenalidomide is another regimen which is approved in patients. This is a phase 2 L-MIND trial, which next slide, which again showed overall response rates of about 58% with a median PFS of 11.6 and a median OS of 33.5. But the best subgroup would be those patients who have achieved CR compared to those who have a PR or stable disease. Next slide. Another couple of slides on the newer drugs, the loncastuximab, which again looked at the Lotus trial. Next slide, which showed a decent ORR of 48.3 with a CR of 24.1 and a PFS of 4.9 months. Next slide. Selinexor is another drug which has been looked at in relapsed refractory DLBCL, and this SADAL phase 2 trial has shown an overall response rate of 28% with 12% patients achieving CR and 17% achieving PR. So having looked at all these three different subgroups of treatment options in the relapsed refractory setting, let's consolidate with the guideline. Next slide. So the EHA guidelines for algorithm for second line and third line would be to stratify patients by time to failure, less than 12 months. If they are eligible for CAR-T, take them up for CAR-T cell. If no intention to proceed to CAR-T, glofitamab with GemOx is 1 year recommendation, otherwise second line therapies. In those with relapsed after 12 months, if they are transplant eligible, give them chemotherapy followed by transplant if they are in CR or PR. And if there's no intention for transplant, again, glofitamab with GemOx is 1 year recommendation, otherwise second line therapies. In third line, the decision is influenced by the prior treatment, condition of the patient, and whether CAR-T was incorporated or not. The options would include CAR-T cell therapy, bispecifics, tafasitamab with lenalidomide, Pola BR, or in limited stage radiation therapy and incorporation into clinical trials. So with this, I think I'll summarize my presentation. Next slide. About 1/3 of the patients with DLBCL have got refractory or relapsed disease after first-line therapy, and definitely effective second-line therapies. The conventional chemotherapies have not changed much. So CAR-T cell therapy and bispecifics would probably be the game changers. The introduction of CAR-T cell therapy has improved survival. Bispecific antibody combination regimens have improved outcomes in the relapsed refractory settings and have moved up the ladder as early options. And innovative treatments are currently under investigation to evolve the treatment landscape in relapsed refractory DLBCL. With this, I thank everyone for a very patient hearing and I hand it back to the organizers. Thank you.
Thank you, Dr. Anand Pai. Excellent presentation as always. I would like to conclude this session. Next we are going to the panel discussion, which is headed by our eminent medical and senior most medical oncologist, Dr. Krishna Prasad sir, and who is the chief medical oncologist and head at Mangalore Institute of Oncology. And as panelist, I would like to invite Dr. Vishwanath, senior consultant medical oncologist at Apollo, Dr. Karthik S. Udupa, senior professor at KMC Manipal, and Dr. Anand Pai, senior professor and HOD at KMC Manipal, Dr. Dinesh Sheth sir, professor and HOD at Department of Medical Oncology, Father Muller's Medical College, and Dr. Nishita, senior professor, Department of Medical Oncology at Father Muller's, and Dr. Hemant, senior consultant medical oncologist at Mangalore Institute of Oncology, Mangalore.
Yeah, thanks, Rachan, for this. I see that all are very senior medical oncologists, and the senior most is the moderator. Can I share the slides? Is it shared?
Yes, sir. Yes, sir. Visible, sir.
Yeah, thank you. So we heard quite interesting and very good talks on Hodgkin's lymphoma, DLBCL frontline as well as second line. And the discussion on Hodgkin's lymphoma was really very good. So let's try to make this as interesting as possible. So first line treatment of diffuse large B-cell lymphoma. So disclaimer is this session is sponsored by Roche. So I think we'll first straight away jump to the POLARIX study, which was presented beautifully by Vishwanath. We know that the progression-free survival at 2 years with POLO-R-CHP was significant compared to R-CHOP. And this, interestingly, has been maintained in the recent publication at the end of 5 years. So if you look at the hazard ratio from 0.73, now 0.76 and 0.77. So this maintenance of PFS benefit at the end of 5 years, I think, is extremely important. Even the disease-free, the patients who achieved complete remission tend to have, maintaining their remission over a period of time. Again, this is extremely important so that patients who are actually doing well continue to do well, and you have a remission which is quite durable. The overall survival in the population, there is no statistically significance, but you can see that numerically fewer deaths are seen in the POLA-R-CHP versus R-CHOP. Now, with this background, let us go into 4 case studies, quickly 5 minutes each probably. So this is a 48-year-old male patient presenting with abdominal pain, low backache, and weight loss of 3 months. He had a palpable abdominal mass and tenderness, elevated LDH. CT showed a thickening of stomach wall, multiple enlarged lymph nodes, and a mass in the right kidney. Upper GI scopy confirmed the gastric mass. Biopsy was DLBCL, non-GCB type. CMYC positive, BCL2 positive, FISH negative for anything, and ECOG performance status 1. So this is stage 4 disease, IPI score 3. So with this, Dinesh, sir, how would you manage this patient? What are your thoughts when this patient has come to you?
So good evening. So this patient is young, but has stage 4 disease and non-GCB subtype and double expressor, having gastric DLBCL. There is also involvement of the kidney. So that will increase the overall the risk of even the CNS risk will be a little higher in this patient. So I will consider considering the IPS score of 3. I will consider POLA-R-CHP for this patient.
Fair enough. Nishita, what is your thoughts when this patient has come to you?
Good evening to all. Yeah, I agree with Dinesh, sir. So maybe my options would be either Pola R-CHP or R-EPOC because it's aggressive disease. It's a double expressor. So I would go for either R-EPOC or Pola R-CHP.
Fair enough. Karthik, your thoughts on this, and would you start one of those two upfront, or are you worried about anything?
The most worrying thing is the disease burden. So I think preface is one thing which we all have to keep in mind. See the LDH, see the tumor lysis parameter. In case the patient is having active tumor lysis, maybe we have to hydrate and give a preface, then go with either one of this regimen. Maybe if my choice would be Pola or CHP only here.
So, Karthik, what prophase would you start?
Most of the time we give cyclophosphamide with the Visalon for 5 days. That is how we are actually titrating I mean, we are giving a preface, but there are, in few of the affordable patients, we have given rituximab with the cyclophosphamide and Visalon also.
Fair enough. Yeah, I think Anant, your thoughts? What are you worried about apart from tumor lysis syndrome? Anything else?
Yeah, there's a large gastric mass, sir. So perforation is one thing which we should be little worried. So I do agree with Karthik that probably we would give a preface, rituximab based preface would be very ideal, and consolidate. That will give them time to organize the finances for Pola as well. So Pola RCHP would be the choice, but I would probably give a preface. The other thing is mass in the right kidney. So that is another thing we need to keep in mind for worsening renal failure and for TLS, both.
Yeah, I think so. Yeah, fair enough. I think my initial thoughts in this patient is I'm very worried about the perforation. Hemant, any thoughts?
Yeah, absolutely. This patient I'd be really very careful in the initial time, probably 1 or 2 doses of endoxan, just kind of debulk the disease and then see how to go about. Perforation, definitely keep my surgeon on the standby and ensure and tell them that I don't need a real major surgery when they go in. Just try and see what best can be done and come out. Because most of the time, if this patient perforates, by the time the aggressiveness of disease, by the time they recover from the surgery, they usually end up having ascites and it's a mess. So the most important point that I would think is make sure that this patient doesn't perforate.
Vishwanath, if you can come in, I think one of my relatives had perforation under you.
Yes, sir. So I totally agree, sir, with all the other panelists that I think we'll have to keep in mind about the perforation and tumor lysis syndrome. But I think Pola or CHP would be the right choice. Like Karthik said, maybe something like a preface would be ideal, and then go ahead with Pola or CHP.
Yeah. So I think it is important that both tumor lysis syndrome and chance of perforation are clearly explained to the relatives, and giving preface reduces the chance of both these things. Also, like I think Anand pointed out, it also gives the relatives the time for arranging the finances and also for decision making to what extent they want to plan for treatment. So in this particular patient, the IPI score seems to be high. Dinesh, can you interpret this one outcomes based on IPI score on R-CHOP? What is your thoughts?
So patients who had 0 to 1 risk factors, they did fairly well in with R-CHOP compared to who had a score of 4 to 5. So the anybody with a high intermediate and high score like 3 to 4 to 5, usually their outcomes are bad even with R-CHOP.
Yeah, I think these curves are very important. You can see clearly that the green curves are those with the low risk, and there is a significant difference between that and the other curves. So as the IPI score increases, then the chances of R-CHOP failure also increases. So, Nishita, your thoughts on this particular Polarix trial? What can you elaborate on what it showed in terms of patients with IPI index score of 2 versus 3 to 5?
So, what they showed is that the benefit is, the PFS benefit is more in high, intermediate, and high. And maybe in the low IPI, the benefit is not as much. However, the overall survival, although the hazard ratio is good, it's not met overall survival benefit.
Fair enough. So I think it is important to know one of the first things we need to do when patient has an advanced DLBCL is to put the IPI score. And if the IPI score is high, then we should think about R-Pola CHP. You can see that the hazard ratio is 0.7 in patients with IPI score 3 to 5. So, what about cell of origin? Karthik, your thoughts about treatment of GCB versus non-GCB subtype?
Yeah, I think this was a interesting trial actually. I think it was called Garden trial where they cell of origin and they had a cluster between C0 to C5 and different clusters were given R CHOP plus a different regimen. Either some got lenalidomide, some got azacitidine. And it showed a significant benefit. So it's a area of interest. But right now, my treatment decision doesn't depend on cell of origin. We are more worried. I mean, we see whether it's ABC or GCB. ABC subset has shown good benefit with Pola RCHP compared to GCB. So that is one thing I'll keep in mind. But definitely, we are not looking into this as of now. Maybe in future we may do this cell of origin and take decision accordingly.
Yeah, one of the criticisms of this PolarX trial is we as clinician depend on the Hans algorithm to differentiate GCB versus non-GCB type, whereas PolarX trial use the LymphGen to differentiate between the various subgroups. Anant, your thoughts on this? How are you subtyping your patients?
Sir, at this point of time, I think we are still relying on the ANS algorithm and classifying them as GCB and ABC. And I do agree that probably we might look at further sub-classification based on either some kind of NGS or exome sequencing to see whether newer information can be achieved to incorporate newer drugs. But at least at this point of time, ABC versus GCB. Just to add a point, if someone has got a high intermediate and an ABC type compared to a high intermediate and GCB type, I would probably push for Pola in ABC type more than I would push in GCB because the ABC definitely we know there's a benefit. So at least otherwise the treatment at this point of time is not changed depending on other factors.
Fair enough. So in this PolarX trial, they did look at the various lymph gen subtypes across the cell of origin group C1 to C5, and they found that C1 and C4 were pretty favorable compared to C2, C3, and C5. So this is pretty clear that when you use the molecular analysis, gene expression profiling, you can divide them into ABC, GCB type, and you can see a huge difference actually in the ABC subgroup. Hemant, what is your thoughts? How are you looking at subgroup or cell of origin analysis, and how are you counseling patients?
Yeah, I think I definitely look at in case this patient is non-GCB. Now, exactly all non-GCBs are not ABC subtype, and based on the lymph chain, definitely there is more overlap on the subtypes. But in case I have somebody who's got non-GCB, definitely I would be counseling more on polar CHP because the impact is drastic, as you see.
Yeah, I think we need to look at this curve very carefully. The 2-year progression-free survival difference is 56% with R-CHOP versus 85% with R-Pola CHP. So I think the ABC subtype, if you want to pick up one subgroup in the POLARIX trial, it has to be the ABC subtype. Vishwanath, you presented it beautifully. What's your thoughts on this?
Sir, I totally agree with you, sir. Like you said, and Dr. Hemant said, I think in ABC subtype, we should definitely consider this, non-GCP. So we should definitely consider this. And if you see the other curve in GCP, it is more or less not statistically significant. So, and the hazard ratio is 1.03. So ABC, we should definitely consider.
Yeah, fair enough. So just to look at this Zing Bling, Dinesh, your thoughts on this, the dark zone signature? Have you looked at it anytime?
No, I have not looked at dark zone signature, but double hit and triple hit lymphomas, like we usually evaluate whenever somebody is ISC positive for MIC and either BCL2 or 6 positive, and fish test usually we get it done to see whether they are double hit or triple hit, but never done the DG signature.
Yeah, so this dark zone signature, patients with dark zone signature seems to overlap nicely with the high risk, high grade large B cell lymphoma, which is double hit or triple hit. Nishita, your thoughts? I want to know from you. Do you do gene expression profiling to look or fish testing to see for double hit or triple hit in all your DLBCLs or only few?
So whenever I have a double expressor, I definitely would want to see whether it is a double hit. And otherwise, only if certain features are there, like high grade, high Ki67, lot of extensive disease, one CMIC is positive. There, in such cases, also I would want to do.
Fair enough. So, so I think what is known in this particular case is patients with a high IPI index and patients with the ABC subtype. These are two very important subgroups where you would think of R-pola CHP. So we'll go to the next case. This is a 61-year-old female, newly diagnosed DLBCL. PET CT shows multiple lymph nodes on both sides of the diaphragm. She has bone marrow involvement and a poor IPI score, and CNS IPI is 5. And the basically it's a double hit lymphoma. Karthik, do you use the CNS IPI? And what is your take on double hit lymphoma?
We are using CNS IPA, sir, to restratify. And most of the people who have a high CNS IPA, we are giving intrathecal methotrexate. So this patient double hit, I think the fish has come positive, right? Yeah, double hit lymphoma. So again, this patient poor performance status, high elevated LDH, IPS score is high. Definitely, she will require prephase. And if the PS improves, maybe go with the R dose adjusted epoch.
Okay. Anant, what is your thought on this patient?
Yes, sir. Again, I think probably I would give preface, but then probably I would give the option of DIPOC R versus Pola R CHP also. Double hit lymphoma, I think the trial had less number of double hit and triple hits, more were expressors. But I think I would treat aggressively, probably with not definitely R chop, either DIPOC R or probably Pola R CHP.
What is the turnover time, Anant, in your place for getting this test done to look for the double hit or triple hit lymphoma?
Expressor, we do in-house IHC, sir, but fish, it takes about 10 days because it goes to an external lab, sir. So 10 days. So
How do
we
you manage
consolidate
these
that time.
patients in that case?
We consolidate that time by giving a preface, especially in cases like this with a poor PS, aggressive disease, high Ki67, hydrate TLS, and then give a preface. And by the time, if it comes as double it or triple it, we tell them the prognosis is bad, better to be more aggressive in terms of incorporating or giving a infusional therapy.
Fair enough. Hemant, what is your thoughts on this patient?
Yeah, overall general condition and I think disease burden is high. Start with prephase, and because it's a double hit lymphoma, I'd probably use R-epoch in this setting.
Fair enough. Vishwanath, in your practice, how do you manage patients with high CNS IPI?
Uh, Yes, sir, I agree with the other panelists, but this patient, I generally resort to R-epoch, dose-adjusted R-epoch only for patients less than 50 to be very realistic, because the idea of dose-adjusted R-epoch is not just to achieve, we have to also escalate every cycle. And we have seen that when we start escalating, that's when the patients have a lot of toxicity, febrile neutropenias. So I agree with Anant Pai that this patient, I would definitely go for Pola R CHP. And dose adjusted epoch R, the problem with this patient would be to escalate the doses. We may be able to give the baseline dose, but the benefit comes only when you escalate in subsequent cycles.
Okay. Dinesh, what is your thought on this case?
So this patient has diabetes, but controlled on medications, and so I will, considering the age, I agree with Dr. Vishwanath that tolerating dose-adjusted R-epoch will be difficult, and I will consider Pola R-chip for this patient.
Fair enough. And Nishita?
Yeah, so it depends, sir, because currently I'm having a 63-year-old who's taking dose adjusted Aripoc. I could go one level up in him. So it depends. I think it's patient to patient wise.
Fair enough. So from what I can gather, there is a trend towards being aggressive in these patients. Some of you would use an R epoch, some of you would use a Pola RCHP. So, a double hit versus a double expressor, there are a lot of studies in these patients, and none of them have really shown anything great. In fact, when they did dose adjusted R epoch versus R chop in DLBCL, there was no significant difference. But in the subgroup analysis, it showed that patients with the double hit would probably benefit. When you look at the POLARIX trial, Vishwanath, if you can come on it, what did actually POLARIX show?
Sir, POLARIX, if you see that the double expressor patients if you see the hazard ratio, it was 0.65. And this was actually, and the non-double expressor, we don't know whether these patients had a GCB or non-GCB, but if you see, the hazards were not that great. And so that's the main thing which I could infer from this. Is there
So I
anything?
think, like Vishwanath said, if you look at the top forest plot, you can see clearly that patients with double expressor are the ones who really benefit from this. And when you come little down, you can see that the double hit lymphomas are not the ones who actually benefited from it. But if you look carefully, the number is extremely small. So, of a total group of around 800 patients, only 45 had double hit or triple hit lymphoma. So, it's a small number, but these are the group of patients in whom you would have expected and more aggressive treatment to be more effective. Unfortunately, I think the small number precludes us from taking any decision. But I think all of us would have been very happy if this had shown some benefit, however small the number was. So overall, if you have a double hit lymphoma, you should think of a polar RCHP. Double hit, it is not a very clear thing. So we'll go to the third case, a 71-year-old male with newly diagnosed DLBCL. So this is an elderly patient. So there is a bulky right tonsillar mass extending into the parapharyngeal space and another lesion, 5.2 centimeter on the PET scan in the right palatine tonsil. DLBCL stage 2, IPI index 3 and CNS IPI 3. So Hemant, what is your thoughts? How would you manage this patient? Hemant, are you there or you're referring that to me? I think Hemant has referred that patient to me. So, Anant, what will you do with this patient?
So 71-year-old, but good performance status.
Yeah.
Tonsillar lesion extending into the space. So probably, I think limited disease and good IPI score 3, stage 1. So probably GCB subtype, sir. So probably I would give them the option of R-CHOP as one of the options, sir. R-CHOP or R-mini CHOP, depending on other
Fair,
comorbidities. No comorbidities. So R-CHOP, sir, probably. 4 cycles and then consolidate with probably R.
fair enough. Karthik, what about you?
This patient 71 is a little tricky age. I feel that our 71 patients may not tolerate R chop. So for me, go with R mini chop because it's a GCB subtype and stage 2, probably R mini chop and then reassess after 4 sites.
Fair enough, I think. Dinesh, what would you do?
So I agree. Our mini chop 4 cycles followed by RT.
Yeah, I think most of us would probably think of minimizing the toxicity by using R mini chop, especially when the stage is early. Would you go with the triple IT or IT methotrexate for this patient, Nishita?
For this patient, I would not, sir.
Okay, fine. Vishwanath, what would you do for this patient?
Sir, I agree, sir. I think our mini chop would be good, and maybe because the IPI score is 3, maybe instead of vincristine we could also use polatuzumab. So that is something with some mini R-CHOP doses. I mean mini R-CHP doses. That is something which we don't have data for, but that is something which we have also tried in our clinical practice, and they have, especially 75, 80-year-old and all, they've tolerated polatuzumab very well.
Hemant, have you come back?
Hello, yes, yeah. I think our mini chop is what is a usual practice, but I think we have a case of somebody more elder than this who had same like extranodal presentation. We gave our mini chop and our COP radiated, but by that time he had a relapse. We ended up giving him polar beer, which he tolerated very well, and he's in CR now. So I think over time we will know how to handle the drug better. So neutropenia is something that we need to be cautious, but I think it is still something that we can handle.
Yeah, so I think sometimes assessing the fitness of these patients is important. A 71-year-old may be very frail, or somebody might be very fit. So, our mini chop probably is one of the standard regimens which we would use. In the elderly subgroup analysis done for these patients in Polarix trial, it seems that patients who are elderly did significantly benefit from polatuzumab. So, interestingly, the older you are, more likely you are going to benefit from polatuzumab. Vishwanath, is it true?
Yes, sir. At least, I mean, I just have a handful of patients, but I'm sure you will have many patients, sir. But I feel they tolerate well, sir. In fact, the oldest I have treated is an 89-year-old who tolerated polatuzumab well.
Okay, fair enough. Dinesh, is this something on your mind that older the patient, you would more likely use polatuzumab?
Yeah, because they are not tolerating the vincristine that well, and polatuzumab tolerance in the elderly is like really good. So I will consider in elderly patients using polatuzumab instead of vincristine.
Fair enough. So I think
Dr. Krishna, sorry to interrupt, but can I request you to conclude in the next 2 minutes
Oh,
because we are running short of
yeah.
time.
Oh, sure. So I think.
Sure. Please continue.
So I think till now we have seen 3 cases, and we have seen that patients with advanced disease, high IPI index, elderly patients and the ABC subtype are the ones who really benefit from this. So I think let us go to the last case, 32-year-old male patient with fatigue, night sweats and unintentional weight loss, and patients with basically stage 4 disease with high IPI index, non-GCB type. So these are the last questions. So this is a young patient, HIV positive. Dinesh, how would you treat this patient?
I will treat with R-CHOP.
Okay. So you would not consider polatuzumab in these patients?
No, because I think Polarix trial did not have the patients with HIV. So I have no idea whether it's going to make any difference in this patient. So I will consider R-CHOP.
Fair enough. Nishita, your thoughts?
So as Sir said, I think HIV patients were not included, but again, I would see like the CD4 count and all those things, sir. I think it will be a joint decision.
So how comfortable are you in giving rituximab in patients with HIV with CD4 count very low?
Um, I have used it. Like, I'm more worried about hepatitis reactivation, about HIV reactivation, because majority of the patients who have come with CD4 low have either come with a T cell lymphoma or plasmablastic lymphomas. So I have
Yeah,
used. It's not like an absolute contraindication, I feel.
fair enough. Karthik, your thoughts on this?
Sir, I think I won't shy away from using Pola RCHP because I think we can extrapolate and use this regimen in HIV positive also.
Fair enough. Anand?
Sir, I did have a patient who was HIV and DLBCL with the double expressor, and I did offer Pola RCHP. Having said that, there's no evidence of in the trial of HIV positive patients. So I agreed upon a shared decision making, but however, the patient did not opt for Pola.
Okay. So he took his share. Fine. Hemant, your final thoughts?
Yeah, I think probably I would see literature in case there are reports where I can use, probably I would use it. The concern for me would be iris in case somebody who had a very low CD4 count. We had somebody who had a very low CD4 count, no iris, but the disease came back as soon as the last cycle was over.
Yeah. Vishwanath, your final thoughts and then back to the organizers.
Sir, I think like you said, we'll have to the evidence is sparse. We'll have to generate evidence, but I think any of them would be right answers, including the young patient dose adjusted epoch are also would be a option.
Yeah. So I conclude by saying that you need to think about polatuzumab in all patients with DLBCL, but especially in patients who are ABC subtype, who have got a high IPI index, and patients who are elderly. With that, I hand it over to the organizers and thank you for this opportunity.
Thank you, sir.
At the outset, I would like to thank Krishna Prasad sir and thank all the panelists for this excellent session and moderated by Krishna Prasad sir. By this, we are concluding this DLBCL talk and we'll go on to CLL talk. And for that, I would like to welcome Dr. Abhay Kumar. We'll be talking about upfront therapy of BTK inhibitors versus venetoclax-based approaches. Dr. Abhay Kumar is a consultant medical oncologist at Manipal Hospitals, Bangalore.
Yes, Shivanand. Sorry, I missed your call. Ada Ramane. Repeat ಮಾಡಬೇಕಾದ್ರೆ.
Yeah. Good evening, everybody.
100%.
So at the outset, I am thankful to Rachan for giving this platform.
The only thing
So-
you can do is you can wait for 2-3 days,
So
because if the liquid biopsy picks
discussing
up
about
some mutation, you can avoid the biopsy.
so discussing about the
Yeah.
new advances in the frontline management of CLL by
See,
SLL.
actually,
So whether
it
BTK
doesn't
inhibitors
matter,
versus
because if you pick up any mutation, whether it is EGFR, ALK, or ROS, the treatment doesn't change whether it is adeno or squamous or adenosquamous. If you don't pick up the mutation, then you have to do it. So what?
Krishna Prasad sir.
I think what you do is you proceed with radiation, wait for 2-3 days, then another 5 days, I think.
Yeah, so we'll discuss the following heading. To select the first line therapy for treating treatment new CLL. So considering the available evidence based upon the whatever the evidence we have, and based upon the expert and guideline recommendations, mainly NCCN guidelines, and the toxicity profile of individual agents, including chemotherapy, and the prognostic variables where patients is having whether TP53 mutation, 17p deletion, and comorbidities, whether patient is having cardiac comorbidities or not, and whether duration of the therapy, whether continuous therapy is required or fixed duration therapy is required, and patient preference. And also we'll discuss regarding the intra-class differences in selectivity, binding, efficacy, adverse effect profile of targeted agents used to treat CLL or SLL. So we all know the initial workup of CLL with diagnosis includes flow cytometry, followed by FISH CLL panel to know the prognostication, and IGHV mutation analysis, imaging, and bone marrow examination is not required initially. So we know that FISH defects 17p deletion is associated with more unfavorable prognostic marker, and 13q deletion will be more favorable, and intermediate, and patients with IGHV unmutated, that is less than 2% mutation or high mutation more than 98%, are considered as higher risk, whereas IGHV mutation is considered as a lower risk. So we know about the CLL dynamic. So when around 33% never require therapy, and around 33% require a therapy at the time of diagnosis, and around 33% patients may not require at the time of diagnosis, they may progress and require treatment. And around nearly 2/3 of the patients of CLL may require therapy in some other later time. So the indication treatment, so patients will be having disease-related symptoms, fatigue, fever, massive splenomegaly, lymphadenopathy, bulky lymphadenopathy, and progressive marrow failure, that is anemia, thrombocytopenia, autoimmune complications are not responding to steroids, and also the doubling time of the lymphocyte count in less than 6 months. We have various these trials, all they have been compared with the combination of anti-CD20 antibody, monoclonal antibodies. The primary endpoint of for all these are PFS, and all these molecules found to be superior compared to the chemo immunotherapy combinations. So we have a study for ibrutinib combination with anti-CD20 monoclonal antibody in frail patients, in older patients, and fit patients. And acalabrutinib with or without obinutuzumab, we have
Hello, what happened?
So just checking. Just give me 1 minute.
Dr. Abhay, are you able to hear us?
so slides are visible, na?
Yes, sir, slides are visible, but your voice is blurring.
Okay.
Yeah, it's fine now.
Yeah. So now, if you see the NCCN guidelines for first line treating patients without deletion 17p and 50 mutation, so we have a BCL2 based therapy, that is fixed duration therapies or continuous therapy, that is BTK inhibitor based therapies. The category 1 recommendations are venetoclax plus obinutuzumab or venetoclax plus acalabrutinib with or without obinutuzumab. So BTK based inhibitors will be acalabrutinib with or without and ibrutinib is category 1. And we have also options where ibrutinib is combined with venetoclax or single agent ibrutinib. And this is the group where we may consider chemotherapy, especially patients who are having IgM mutations. Whereas in patients with deletion 17p and TP3 mutation, the treatment protocol remains to be same except chemoimmunotherapy combination. So the first line treatment options basically are 4 options. So either BTK inhibitor based therapies, that is acalabrutinib with or without obinutuzumab, zanubrutinib, or time limit continuous therapies, that is venetoclax acalabrutinib is completes in 14 months. So whether the patient is to add any infusions, then we have option of either single agent BTK inhibitors or venetoclax acalabrutinib, so which all constitutes oral therapy. So whether patient is having any underlying bleeding complications or significant cardiac diseases, then we have to avoid BTK inhibitor therapy. So whether the patient is having underlying renal impairment, then we have to be very careful or may avoid this combination because it increases the risk of TS. So if the patient is having deletion 17p or p53. So if patient is having deletion 17p53, so chemotherapy has to be totally avoided. And BTK inhibitors have to control the disease better than the BCL2 inhibitors. So coming to the individual agent, so acalabrutinib, so which is a second generation BTK inhibitor, it's a more selective kinase inhibitor associated with fewer side effects. So it is highly effective. So its activity appears to be comparable with ibrutinib. So overall response rate is 90% and 5-year PFS is 72%. It is equally efficacious in IGHV mutated versus unmutated. And it is so in the initial pivotal study in the Elevate RR, it is better tolerated, associated with less arthralgia, myalgia, less hypertension, atrial fibrillation, atrial flutter, and less complications. It may cause headache. The approved dose is 100 mg twice a day, so it can be combined with the obinutuzumab. So this is the study of first line acalabrutinib, so which can be used with or without obinutuzumab versus compared with the chemotherapy, close and obinutuzumab TN study. If you see them, it is basically a 3-arm study where obinutuzumab has been used along with acalabrutinib or acalabrutinib used or obinutuzumab is the third arm, that is comparative arm. Both acalabrutinib arm, that is monotherapy versus obinutuzumab arm, so which is done in terms of PFS benefit compared with the obinutuzumab. So, but median PFS in all three arms is not reached. So this is the latest 6-year follow-up of this Elevate TN trial. So you can see that both acalabrutinib arm significant PFS benefit compared to the chemo arm. The median PFS is only 27 months in the chlorambucil obinutuzumab arm, so which is not reached in the both arms. So, and the PFS when we compare the monotherapy arm, it is 0.24. In the combination arm, it is 0.14. So, which is significantly better in the latest 6-year follow-up. So then the next molecule is zanubrutinib. It is also a second generation BTK inhibitor, more selective, fewer side effects, found to be superior to bendamustine rituximab in the first line CLL based upon the SECURE trial. Even one study has shown that it is superior to ibrutinib in the relapse refractory setting based upon the Alpine trial. Overall response rate fire PFS is around 76%. It is also equally effective in both IGHV mutated and unmutated. And in the Alpine study, it has found to be having less atrial fibrillation, less bleeding, and less diarrhea. But hypertension appears to be similar to ibrutinib. Approved dose is 160 mg twice a day. So this is a first line trial versus chemotherapy. You see the curves, there is a significant PFS benefit that is 0.29 in favor of zanubrutinib, whereas the median PFS is not reached versus 44 months in the chemotherapy arm, chemoimmuno arm. And if you see the subgroup based upon the IGHV mutation versus unmutation, there's no much difference in the zanubrutinib group. So as we know that it works equally well in both mutated and unmutated group. Whereas when we dissect and see mutated group versus unmutated groups, is significantly better compared with the chemotherapy arm. Just 1 minute. So if you see the Sequoia cohort 2 study with patients with deletion 17p, that is a patient with high risk group, you can see around patient is having consistent CR rates even after 3.5 years with the PFS of around 79% and OS 89% even after the 3.5 years. So when we see the individual BTK inhibitors, all three molecules, so in the Elevate RR, acalabrutinib is found to be equally effective to ibrutinib, but less toxicity. In the Alpine trial, zanubrutinib is found to be superior to ibrutinib, and again, better toxicity profile. Aspen trial is basically in the Waldenström's macroglobulinemia. So when zanubrutinib appears to be more effective again and well tolerable compared with the ibrutinib. Next is the BCL2 inhibitor venetoclax. So again, it is also highly efficacious. The remission are deeper with the venetoclax compared with the BTK inhibitors. That's why we look into the MRD status in when patients received BCL2 inhibitors. There are more MRD negativity and more CRs can be achieved with the venetoclax. It's basically a fixed duration therapy that is 12 months duration, and it is combined with the obinutuzumab in the first line and also with the acalabrutinib. Response rate is 90%, 5-year PFS is 63%. It has more activity in the IGHV mutated compared with the unmutated, and it's generally well tolerated with some specific side effects, especially tumor lysis syndrome. The side effects especially include diarrhea, nausea, and neutropenia, and especially important about managing the tumor lysis syndrome. That is why there is a protocol called as a ramp up dosage. That is week 1 to give only 20 mg, week 2 50 mg, week 3 100 mg, week 4 200 mg, week 5 400 mg. So there is a protocol for how to manage this TLS associated with venetoclax. So basically, we divide them into low risk, intermediate, high risk based upon the bulk adenopathy and absolute lymphocyte count. So if a patient is low risk, hydration is required, allopurinol is required, and outpatient we can manage. And we do usually lab parameters before 68 hour post, 24 hours post, first dose of 20 mg and 50 mg, and then before pre-dose at subsequent wrap-up dose. In intermediate risk, again, the same has to be followed. Ramp-up dose, pre-dose as well as 6 to 8 hour, 24 hour, between 20 mg and 50 mg. Again, outpatient management. When the patient is having high risk, that is bulky disease, lymphadenopathy is more than 10 centimeter, or absolute lymphocyte count is more than 25. So inpatient administration is required first to ramp up dose. So patient requires oral as well as IV hydration. Allopurinol has to be continued, and sometimes may consider raspberry case based upon the baseline uric acid. Again, regularly we have to monitor like pre-dose 6 to 8 hours, 24 hours tumor TLS parameters. So this is the study of venetoclax plus obinutuzumab compared with chlorambucil obinutuzumab in CLL4. So phase 3 randomized study. So this is a follow-up data. There's a separation of curves after 1 year. The median PFS, you can see nearly 40 months benefit, more than 3 years in favor of venetoclax obinutuzumab compared with chemo obinutuzumab with significant hazard ratio of 0.40. With 6-year PFS is 53%, which is more than double compared with the 21 months in the chemo obinutuzumab arm. So when you see the patients based upon the T53 and IGHV mutation, so it is done equally well patient in both T53 mutation as well as non-mutation. Whereas in the P53 mutation, the PFS is around 52 months. In no T53 mutation, it is around 76 months. Whereas patients with IGHV unmutated is not done well compared to the IGHV mutation. Yes, it is not IGHV mutated, whereas it is 64 months in unmutated. So Amplify is the another study of venetoclax. So phase 3 randomized study, 3-arm study. So where one group received combination of acalabrutinib venetoclax, other one is plus or minus obinutuzumab, third group is chemotherapy group. The primary endpoint is PFS, comparing between two drugs versus chemotherapy, whereas secondary endpoints include comparing the PFS, three drugs versus chemo, OS, a comparison between them, and also undetectable MRD, and as well as overall survival. So you see the 3-year data, PFS data. So the both venetoclax group are significantly better in terms of PFS with significant hazard ratios. The 3-year milestone, 66% in the chemotherapy arm are having PFS benefit, whereas 76 and 83% patients with who are receiving AV and AVO combination are deriving significant benefit. So when you see the overall survival data in this Amplify overall survival data, which is significantly better in the only acalabrutinib venetoclax arm compared with the obinutuzumab arm. This is basically due to during the study period, many of the COVID deaths have been seen in the patients with obinutuzumab arm. So when patients are censored with the COVID-19 death, then obviously the benefit with the overall survival benefit is seen in the both group compared with the chemotherapy. So when you see the undetectable MRD status, which is quite high in the triple combination of as well as chemo arm compared with the patient who has received just only venetoclax or the compared with the chemoimmunotherapy arm. So what is the best initial therapy for trial 70%, whereas in the elevate acalabrutinib have and in the venetoclax patient IGHV unmutated is not well. So IGHV it is 75 here. So was not done that 69% 3-year PFS. In amplified trial again, the
Hello.
Yeah, Dr. Rachan, Dr. Abe has left. I think he is facing network issue.
Yeah, I think because of time constraints, we will wind up this talk. If Dr. Abe is okay, can you please contact him?
I'll contact him. In the meantime, we can begin the next talk if you are
Yeah.
fine with it.
Yeah, we will go to the because of time constraint is already is 9:15. So we will go to the next talk, that is a sponsored session.
Dr. Abe is back.
We'll finish in one slide is remaining.
Sure.
Yeah, so this is last slide. So covalent BTK inhibitors preferred, especially for older, frail patients with CLL, which is simple and safe. Indefinite therapy is less of an issue. So patient with the P53 mutation, so data with BTK inhibitors is impressive. Acalabrutinib versus zanubrutinib between them. So the comparison, there is actually no data, but acalabrutinib is available to us, and which is even cheaper. Whereas time limited therapy is recommended if there is a IGHV unmutated, can be avoided, especially if patient is having IGHV unmutated, we can avoid. Whereas in IGHV mutated, we can consider. And we have having three options: venetoclax, obinutuzumab with the acalabrutinib venetoclax. We can discuss the pros and cons with the patient. Thank you.
We would start with the sponsor session, that is zanubrutinib talk. And the talk, Dr. Vishwanath's talk, will skip because of time constraints. At the outset, I would like to thank Landmark Oncology for sponsoring this session. Today's talk is zanubrutinib unleashed, redefining management of B-cell lymphomas. Next slide, please. Next slide. So the need for newer BTK inhibitors, as we know, more than ibrutinib demonstrated more than 50% inhibition of 17 kinases other than BTK, and these other extra inhibition is responsible for side effects like atrial fibrillation, bleeding events, and rash and diarrhea. C-terminal SRC kinase is responsible for the atrial fibrillation, and TEC family kinases for bleeding events, and EGFR for rash and diarrhea. So adverse events led to the treatment discontinuation about 23% of patients in clinical studies and 49% of patients in real world. Next slide, please. So coming to the zanubrutinib drug profile, it's a next generation highly potent selective irreversible BTK inhibitor. By inhibiting BTK, they inhibits B cell proliferation, trafficking, chemotaxis, and adhesion. Next slide. Next slide. So the difference between zanubrutinib and other BTK inhibitors is zanubrutinib doesn't have off-target kinase activation. So when you can see, zanubrutinib has the least off-target activation compared to ibrutinib and acalabrutinib, and the molecule and the once it is the active metabolite of acalabrutinib also has many off-site activation. Next slide, please. So coming to dosing advantages, no dose adjustment necessary due to improved drug and drug to food interactions, and no significant alteration with high calorie or high fat meals or low calorie or low fat meals. Gastric acid reducing agents also do not affect. Oral anticoagulants also do not affect. So it can be a once a day dose or a twice daily dosing. So 320 milligram of daily dose. And in severe hepatic impairment only the dose reduction is necessary. 80 milligram BID in severe hepatic impairment. Next slide, please. Now coming to indication, since it's a newer BTK inhibitors which has a least toxicity profile, So it is approved in CLL as a first line in and Waldenstrom's macroglobulinemia adult patients in first line. In mantle cell lymphoma, adult patients who have received at least one prior therapy, and marginal zone lymphoma who have at least received one anti-CD20 based regimen, either and refractory marginal zone lymphoma, and follicular lymphoma, relapsed or refractory in combination with the obinutuzumab after 2 or more lines of systemic therapy. Next slide, please. Coming to clinical evidence in CLL, which is approved in first line. Next slide, please. Based on this Alpine trial, zanubrutinib versus ibrutinib in relapsed refractory CLL and SLL. Next slide. Now, in this, the primary endpoints was overall response rate, and secondary endpoints were PFS, and it was compared against ibrutinib 420 mg, 160 mg BID versus ibrutinib 420 mg OD. Next slide. The overall best overall response, as you can see, is significantly high, 83.5% versus 74.2%, and independent central review, it was 86% versus 75%, and you can see CR rates was also marginally higher. Next slide. And the PFS benefit, there is 32% relative risk reduction in disease progression or death at the end of 3 years. Progression-free survival of 65 versus 54%. Next slide. And 49% relative risk reduction in disease progression of death, even in patients with deletion 17 positive patients. So there's even in high risk patients, it did well, 59 versus 38%. Next slide, please. Coming to new cases, new patient CLL, bendamustine rituximab versus zanubrutinib in previously untreated CLL bar SLL. Next slide. In these patients, the regular treatment naive patients more than 65 years or less than 65 years age unsuitable for FCR treatment were taken, and they're stratified based on age, less than 65 or more than 65, Binet staging, IGH mutation status, and geographic region. So the arm 1 had zanubrutinib BID, and arm B had bendamustine rituximab. And in cohort 2, with the high risk cohort, that is deletion with no deletion, second cohort had patient with deletion 17p, and they received either zanubrutinib or zanubrutinib plus venetoclax. So high risk cohort received only zanubrutinib or zanubrutinib plus venetoclax, and safety and survival were analyzed. Now coming to the data, next slide. So there was superior PFS in versus BR in patients without deletion 17p in cohort 1, even with those having mutated IGH status, and there was 70% reduction, risk reduction of death with the at the end of 3 years, and the estimated 42-month PFS rate was seen with zanubrutinib and BR compared to BR. PFS was not reached in zanubrutinib, and 42 months PFS rate with the BR, and PFS was significantly improved with zanubrutinib versus BR in patients with mutated and unmutated immunoglobulin heavy chain mutation. Next slide. Even second cohort, which included deletion 17p patient, the overall response rate was 97.3%. Median OS was not reached. Estimated 5-year OS rate was 85%, and estimated 5-year OS 60-month OS rate was 87%. Next slide. So in the third cohort, which used zanubrutinib plus venetoclax, with or without deletion 17p or p53 mutation, the 2-year PFS rate was 92%, oral response rate was 97%, and CR and CR incomplete was 49%. So it significantly showed benefit. Next slide, please. Now coming to, since there is no head-to-head data between zanubrutinib versus acalabrutinib, so in the head-to-head data is not there. So matching adjusted indirect comparison was done, where the individual patient data were matched based on age, deletion 17p status, and IGH mutation status and aggregated and it was weighted for the population for fair comparison, and based on this, next slide, PFS was significantly improved compared to the acalabrutinib in the matching, and OS was potentially improved for zanubrutinib post matching. Next slide. So when in the network meta-analysis, zanubrutinib versus acalabrutinib was venetoclax. So hazard ratio for PFS was 0.41 and 0.3 for unmutated IGH mutation and 0.49 for mutated IGH mutation. So the significantly statistically significant improvement was seen for PFS for zanubrutinib, but the trend towards OS was seen, but OS was not met. Next slide. Again, so after COVID-19 adjustment, zanubrutinib versus venetoclax also showed significant this one 0.66 hazard ratio and 0.89. Longer PFS and trend towards extended OS in this matching adjusted indirect comparison. Next slide. In Waldenstrom's macroglobulinemia, it is zanubrutinib is approved. So as per Aspen trial, next slide. So primary endpoints was in this new cases where who are treatment naive were taken with no prior exposure, and they are into random stratified based on two cohorts, CXCR4 mutation status and MID88 mutation status, randomized to zanubrutinib versus ibrutinib. And so based on this, next slide. Based on this, there is significant overall survival, overall response rate. As you can see, 80% VGPR and PR, and with the CXCR4 and with the MID88, 82 versus at 70, and at 18 months follow-up, 50% of the patients were in VGPR or PR, partial response, and very good partial response is seen in 27%, and 23% of patients had the partial response. Next slide. In cohort 1, treatment naive patients, this again this is a regular patient, CXCR4 patients. So these patients had a 95% oral response rate. Even in relapsed refractory subgroup analysis, it was 94%. Next slide. Pooled cardiac safety. Next slide. The problem with the ibrutinib is atrial fibrillation, and in this pooled cardiac safety, as you can see, the non-cardiac and non-cardiac cardiovascular complications like in ibrutinib are also much lesser with the zanubrutinib. Infections are lesser, hemorrhage, neutropenia were lesser. Next slide. And coming to cardiovascular adverse events, when you see in the first year, atrial fibrillation was very less, 2.1% in the next year, and ventricular arrhythmias were less. As when you compare with the ibrutinib, it is much higher. Atrial fibrillation in the first year is 10%. It increases to 18% after 48 months. So at the end of 48 months with the zanubrutinib is still only 4.3%. Hypertension is also about similar, but it is not, it can be managed. So symptomatic ventricular arrhythmias are also significantly lesser. It is about 2.3%. As time progresses, it increases. Next slide. So the pool cardiac safety rate of treatment emergent atrial fibrillation events was approximately 4-fold lower with zanubrutinib than ibrutinib. And rate of treatment emergent vascular events were also ventricular arrhythmia, were idiopathic ventricular arrhythmia were also significantly lower. Compared with ibrutinib, the proportion of patients with hypertension were lower with zanubrutinib, except in Alpine study where their rates were similar. Next slide. So this is a study where safety was assessed. People who are intolerant to ibrutinib or acalabrutinib, where zanubrutinib was used, BGB 3111 study. Next slide. So previously treated patients who are more than 18 years old who had received either ibrutinib or acalabrutinib or intolerant in opinion of investigator, where toxicities are resolved, and these patients were stratified based on intolerant to ibrutinib or intolerant to acalabrutinib alone, or with acalabrutinib and ibrutinib. So these patients, after screening, were started on zanubrutinib 160 milligram per orally BID or 320 milligram OD. Next slide, please. Treatment was given until progressive disease or unacceptable toxicity. When, as you can see, once we started zanubrutinib, most patients did not have a recurrence of these toxicities. That is, about 67% of the patients that ibrutinib intolerance did not recur. The most common intolerance was fatigue, hypertension, atrial fibrillation, arthralgia, and rash. So, next slide. While reviewing zanubrutinib, 27 of the 37 acalabrutinib intolerant events did not recur. Of those adverse events that did recur during zanubrutinib treatment, none recurred at a higher grade, and 40% of acalabrutinib intolerance events were lower grade. So even if that recurred, they were 40% of them were at a lower grade. Next slide. Now coming to follicular lymphoma. Next slide. Based on Rosewood trial, zanubrutinib plus obinutuzumab in follicular is approved in follicular lymphoma after 2 prior therapies. Next. So these patients who had received at least 2 prior therapies must have received at least an anti-CD20 antibody and an alkylator. So these were stratified based on number of prior lines of therapy, more than 2, or 2 to 3 versus more than 3. Rituximab was a refractory status, geographic region, China versus ex-China. Zanubrutinib versus plus obinutuzumab versus obinutuzumab alone, and safety and survival data were analyzed. Next slide. Primary endpoint was oral response rate. As you can see, oral response rate with zanubrutinib was significantly higher. Oral response 69 versus only 46% in previously treated patients. And coming to median PFS, it was 28 months, and range was 16.1 was not reached, and 10.4 months only with the obinutuzumab. Median OS was not reached versus 34.6 months, and 2-year percentage of median OS was 77 versus 71%. So oral response rate benefit was seen with the obinutuzumab consistently across subgroups, including rituximab refractory and refractory or non-refractory to previous lines, and progression of disease within the last 6 to 12 months of last treatment. Next slide. Coming to mantle cell lymphoma. Next slide, please. Single arm zanubrutinib in relapsed refractory mantle cell lymphoma. Next slide. So in this, the oral response rate was 84% and CR was 78%, and median duration of response was not reached. Next slide. Next slide. In marginal zone lymphoma, next slide. Again, Magnolia trial, this zanubrutinib monotherapy was used in relapsed refractory setting. Next slide. Again, the primary endpoint was oral response rate. Next slide. I can see oral response in extranodal was 64%, and CR was 40% in extranodal, and nodal 76%, CR was 20%, and splenic nodal marginal zone lymphoma was 8%, and unknown type it was 25%. As you can see, the oral result is 26% CR rate with 68% oral response rate. Next slide. So coming to the guideline recommendation, as per NCCN guideline, zanubrutinib is approved in deletion 17p as well as without deletion 17p in first line. Without deletion 17p, it is a category 1 recommendation in first line and second line. With deletion 17p, it's category 2A, and second line it's category 1. Mantle cell lymphoma, it's category 2A for second line, and for subsequent therapy also approved. For Waldenstrom's macroglobulinemia, category 1 recommendation in first line, and also for previously treated Waldenstrom's macroglobulinemia. Zanubrutinib is a category 2A preferred recommendation for second line and subsequent therapy after at least 1 prior anti-CD20 monoclonal antibody based regimen. In follicular lymphoma, it is approved. And to summarize, it's a next generation BTK inhibitor, is a highly potent and selective irreversible BTK inhibitor, low off-target binding, high affinity for BTK and with low off-target binding, including TEC, HERA, and JAK3, which results in hypertension and atrial fibrillation, bleeding events. Superior to other BTK, superior PFS via head-to-head trial and match age-adjusted trials, and especially compared to acalabrutinib, and it has superior cardiac safety data versus ibrutinib. Zanubrutinib is the only BTK inhibitor with the most comprehensive label indication in CLL upfront, CLL in upfront, and Waldenstrom's macroglobulinemia upfront, and MCL and margin zone lymphoma and follicular lone lymphoma after one line of therapy. Next slide. So hereby I end my talk, and I would like to thank all attendees for patient hearing, and the session has gone beyond 9 o'clock, and we are sorry for that. And I'd like to conclude for attending this and participating this and making it a success. I would like to thank Mr. Tarun Mathur and Yashika and Aditya for Horizon Group. I'd like to thank Dr. Vishwanath for the back support, and academic partners, Roche, Glenmark, Zydus, Takeda, and Natco. And I would like to thank each individual for attending this meet and making it a success. Thank you.
Thank you, Rachan.
Thank you, Dr. Rachan Sethi, for giving us the opportunity, and thank you all the faculties for attending. With your permission, we can close the meeting, sir.
Thank you. Thank you. Thanks a lot.
Okay. So supporting, please close the meeting.